Right. Good morning, everybody. Welcome to our public board for NHFT today. I'm going to do a very brief welcome and explain a bit of context, and then hand over to Julia. As part of our planned programme of enhanced support to me as joint chair of LPT and NHFT, we agreed that Julia would take some opportunities to chair the board. And she's very kindly agreed to do that some time ago for this particular meeting. So I just want to sort of say I'm here. And although Julia is in the chair, I'll be actively participating and supporting her. But it was something that NHS England encouraged us to put in place as part of the joint chair arrangement. So I'm sure everyone would be delighted that Julia's in the chair, makes a change, and we'll all support her through the board meeting today. So without any further ado, I'll hand over to you, Julia.
Thank you, Christy. Good morning, everybody. As Christy said, I'm Julia Curtis, Deputy Chair, and I'll be guiding you through today. So a huge welcome from me. Just to remind everybody that the meeting is being recorded today, and that will be available on the public website afterwards. A huge welcome to governors and members of the public who might be observing today. It's really important for us that we have the opportunity for people to observe us in action. So welcome to anybody who's observing. Also welcome to John Murray from Deloitte, who's observing as part of our well-led review. That's really great. And just wanted two more things in the opener to acknowledge this is Scott Adams' last official board meeting as a non-exec director for NHFT, which we're very sad about. We'll have an opportunity, I think, towards the end to speak more personally, Scott, but from me, the passion and commitment that you've shown to the people, public, communities, staff, service users across Northamptonshire in the time I've known you has been absolutely incredible. So a huge thank you from the board for everything, your commitment, etc., your time, your wise words. I've learned such a lot from you, but I think at the end we'll be able to speak a little more fully around that. So thanks, Scott, for all your commitments. And I just wanted to lastly publicly acknowledge the hard work, commitment, again, passion from all our staff, just to put that in the public domain, who are working day after day with huge compassion in very challenging times. So a thank you to all our staff, and we'll have those people in mind and our service users as we go through the board today. So thank you, everybody. Just move on to apologies for absence. I'm not sure there's any formal apologies unless anybody says otherwise. Just wanted to note that Angela is needing to leave at 12 for a pre-agreed personal commitment. So thank you, Angela. And I know Dave Mayer will be here for the rest of the public board meeting and the private meeting afterwards. That's great. In this administrative section, I just want to acknowledge that we have actually had a question from a member of the public. So thank you for that. And the individual raised questions about the way that we as an organisation is implementing our new arrangements around involvees and involvee payments. And we've had the opportunity to consider the question. And I know that we've had information and discussion on this at previous board meetings. And currently the issue, I understand, is being addressed by colleagues in the executive team, and they're picking up the issues. And if we feel it needs to come back, then we'll take the opportunity to do that. So I just wanted to acknowledge and thank the member of the public for doing that. Really important we hear from people, and hopefully the issue is being addressed outside of the meeting. Thank you. So I'll just go on to declarations of interest. If there's any declarations of interest other than those declared for anything on the agenda today. People the opportunity? No, shaking of heads, that's great. So we'll go straight to the minutes of the last meeting, which was the 25th of January. Take them as read. Just any matters of accuracy or any matters arising that anybody thinks are not on the agenda today. I didn't have any, but people are shaking heads, so that's great. We'll take those as approved. Thank you. So move on to the action sheet. There's only two actions. The first one, FT 2405, the risk report, with a couple of potential changes to two of our BAF risks, and I understand that's completed and on the agenda, and I think Richard Smith, our Director of Corporate Governance, will be talking that through in the risk report. And then the open action from previously, the estate strategy, the ongoing capital allocations haven't been released yet, so that's deferred till the end of May, and the refresh of the estate strategy is coming back to us on the 31st of July, I understand. Tim, question.
Only question was, because of the delay due to the capital allocations, we're going to go May, and then the following board meeting we'll have a conversation again about estates. Bearing in mind it's an 18-month refresh, is it worth just dovetailing those two together just for a more efficient use of time? But I'll leave that to Paul to tell us whether he thinks it's right or not.
Handily, Paul has put his hand up.
Yeah, I think because we said that we'd bring the estate's 5-year plan back in 31st of July 2025, so it's actually next summer. So there's that piece of work to do. The annual plan was so that we were all clear, both as a board, but also then at operational levels about what we had commissioned for the year from the capital plan in estates terms. So that annual plan is a very distinct 24-25 piece of work, Julia, whereas the estates 5-year plan, the estate strategy update was a very different piece of work, which will come back next summer.
You content with that, Tim?
Yeah, I'd completely missed the 24-25 distinction between the two. So no, it's good explanation. Thank you, Deb. Paul.
Great. Thanks very much. Thanks, Tim. Thanks, Paul. Okay, so paper C is the work plan for the Board of Directors, and I think Richard's just going to come in with an update around our effectiveness review on this paper. Thanks, Richard.
Thanks very much, Julia. Yes, good morning, everybody. As you'll recall, we normally at this time of the year commission our annual effectiveness review of boards and committees. In light of the review that's underway at the moment with colleagues from Deloitte on our leadership and governance arrangements, we're proposing to defer the start of that review until we have the report from Deloitte, so we can take account of any feedback we get from Deloitte together with our own feedback, which will then inform the future work plan and other matters in terms of the running of the board. So just to confirm that we won't be bringing forward a proposal today for the effectiveness review, but that will come hopefully at the next meeting. Thanks very much.
Thanks, Richard. And the rest of the work programme stands as it is. Yeah, thank you for the update. That's great. Any questions from anybody? Comments on the work programme? No, thanks very much, Richard. So we move on to my favourite part of the board, our patient story. You'll just note there's a change of focus from the published agenda. We have a different service today due to circumstances beyond our control. So we absolutely thank everybody for agreeing to come along today and welcome everybody. So I'm going to hand over to Anne Rackham, our Chief Operating Officer, who's going to introduce everybody and lead us through our patient story. Thank you, Anne.
Thank you, Julia. And yes, I just want to reiterate, due to some unforeseen circumstances last minute, we've had a change of plan, but I'm really grateful and very excited to hear from Tracy Dempster and Sue Dainty, who I've done. Obviously, I work with Tracy, but I've done co-production work with Sue Dainty in the past, and I know she has lots to offer us this morning as well. So welcome to the board. This morning, we're going to be talking about MSK. Our physiotherapy services, and it's been a real struggle following COVID, and we're just going to talk through how we've managed quite a high influx of work, and how the teams have been really innovative in how they've looked at that and sort of risen to the challenge of those demands. And then Sue's going to bring us a personal story, which thank you very much, Sue, for coming in to do that for us. So I'm going to hand over to Tracy, I believe, first.
Thanks, Anne. Thanks. Thank you for inviting me this morning. It's really nice to be here. What I plan to do today is just give you a little bit of an overview of MSK services as they are at the moment and the challenges that we've been facing, and then very quickly bring you on to Sue's story. So I'll just share my screen with you so that you can see Okay, can you all see that? Okay, I can see you, that's excellent. So, so we've got a bit of a summary here of the MSK services as they are at the moment, split into the 4 groups that we've been reporting, the 4 elements that we've been reporting on over the last year. We've been very challenged with wait times in MSK. Just after COVID, we experienced an influx of referrals, as did a lot of services, but also the impact of the acute starting up the machine of elective care again, which put pressure on our urgent and super urgent patient appointments. So we had a very significant wait for routine appointments within the service. This situation is now an awful lot better. The data on the performance reporting is in the pink box, and I won't go through that, but we are reporting on that weekly now, and it's making a lot of difference to have that increased level of oversight on the data. And the sorts of things that have been successful for us have been just picking out slot utilization, so that we identified that as a problem early in the project plan to remediate the waits. So we're pleased now that we're at 98% slot utilisation across the service. And that's a very considerable percentage increase. So what I mean by that is where people have either cancelled appointments early and they haven't been rebooked, or appointments have been held for a reason that we no longer require. So when it gets to the day, you can measure that and work out what our slot utilisation is on the day. So it's a very dynamic measure, but it's excellent to see that that's at 98%, because that means that we're using 98% of our capacity across the service every day. The website development's in progress, which is excellent. And really good to see that. We're going to be including symptom checkers and enhanced patient information, which we're going to promote through our system work with colleagues to primary care, so that we can pick up those people who need to have advice and guidance before they get a referral into MSK. We're still discharging a lot of people before they've even had their first appointment, and that's largely because things do sometimes get better on their own. So we're aiming to fill that gap with some good evidence-based patient information, which will encourage our primary care colleagues to go to as the first point when people start to attend with an MSK issue. And we've now also integrated the patient contact centre within therapies management, and that's really helped to align processes and make sure that we are not duplicating any activity. In terms of service delivery, I'm pleased to say that we filled all our vacancies, and we're starting to see those new staff come online now and get through their supernumerary period. And this is across bands 5, 6, and also our advanced practitioner development posts. We had an issue early on in the pandemic where we were required to move out of Kettering General Hospital because of the needs of that site. We're now progressing the gym space at St Mary's, so a new solution is in progress to create more capacity at this site, and the staff are all really excited to see that. So we're hoping for some good news and be able to move into that facility from spring 24. Our MSK has been a bit of a leading light in terms of the Equivia feedback system, so it's now very well embedded across our MSK teams, and we're starting to receive good levels of patient feedback. And we've also got a new post who's focusing on patient access and the slot utilisation, hence the 98% slot utilisation within the service at the moment. Give you a little bit of a look there at the 52-week waiters and their wait trends. So won't go into the actual numbers, but you can see that we have a few peaks and troughs because we're in holiday periods and things like that, and you can probably pick those out on the graph. But when you look back to the situation in December 22 and Jan 2023, you can see that we're significantly improved and the trajectory continues in that way. So I will hand over to Sue now, who's got a really lovely story to share with you about her experience of MSK. Sue.
Hello, good morning everybody. Thank you for, well, I'm here anyway at the last minute, but thank you for, I'm pleased to be here. So I do know quite a few people, but I'll just introduce myself, give you a little bit of background about myself before I go into the patient story. So basically, my name is Sue Dainty. I was diagnosed with rheumatoid arthritis when I was 8 years old, and when the treatment was a bed rest and aspirins. I have multiple joint replacements. Really, I'm a complex case, you'd say. I'm an active involvee with the Trust, and I'm a volunteer with the new the befriending service, which I really enjoy. And also relevant to the MSK service, the volunteers do reminders, appointment reminders for a clinic over at Daintree Hospital, which I'm involved in, to cut down on the DNAs, which is being really successful, I hear. In addition, I belong to a service user and carer group at the University of Northampton, where I support students in the Faculty of Health, Education and Society. And I predominantly work with nursing, social work and physiotherapy students. So in the classrooms, we do sessions on patient-centred care, communication skills, end of life, just to name but a few. I've been a resident of Northamptonshire all my life, and I have 2 elderly parents living in Northampton. So that is a little bit about me, to put you in the picture. So I'm now going to go into my story. So on the 17th of November 2023, I was due to do a session with the university students. Ironically, it was involving a virtual ward setting. Little did I know, a short time later, I was going to be a real patient at Kettering General Hospital. So I basically fell in my porch. I didn't pick my right foot up, and I hit my right shoulder on the door frame where you step over to come out. I knew that I'd broken it. I've got a lot of experience, so I know it was painful. I couldn't move it. It was weak. So it meant a trip to A&E at Kettering General Hospital, where I was referred to Miami. Well, it's not as exciting as it sounds, but it's minor injuries and minor illness. So I was assessed, x-rayed, and I diagnosed with a fracture in the ball of the shoulder joint. It's this one here. Bearing in mind that I have rheumatoid arthritis, but you know, it's done lots of damage. So that wasn't a good outcome. Bear with me, I'll lose my track. So there was not going to be a virtual setting at the hospital for me. I was experiencing the real life. So I was there 3 hours, which I thought was really good. That was arrival, treatment and a coffee in Costa. And they sent me away with a neck and shoulder strap. So I followed up with attended the Frank Radcliffe Clinic at Kettering General Hospital. And whenever I go into any kind of interaction with a health professional, I call myself a mystery patient experience assessor. So I'm looking out for people's skills, all sorts of things. And that one was mediocre. I won't go into, it was okay. The second appointment I had was at the same clinic with a consultant, and patient-centred care, communication skills, they were dire. I came out and I felt very sad, upset, and I felt angry because of all the work that and the awareness I have around these topics. For somebody to, basically have no people skills at that level, I was horrified. So I did actually contact PALS, and they dealt with it really well. I had bear with me, a telephone call from the sister on the Frank Radcliffe Clinic, and she said, "Would you like me to feed it back to the person concerned?" Now, to start with, I thought, "Ooh, do I do it?" But then I thought, well, if they don't know, they're not going to change whether it makes a difference. So she fed it back to them for me. So that was, bear with me, I'll lose my track. So that was, the follow-up appointment. So then they referred me to physio at Kettering General Hospital. And that was fine. I had one appointment, which, they did a bit of an assessment. So then we come to MSK Physiotherapy Community Service, and that I was referred to those at St Mary's Hospital, Oakwood Centre. The first appointment was quite lengthy because it was my initial assessment, and I really, the words I've got down here: outstanding patient care, passion, empathy. This is the individual, that the person who treated me right through. Active listening, respect, dignity. Recognised I had a lot of experience around my condition, so she worked with me rather than trying to tell me things that I perhaps already knew. Collaborative, we worked together. I thought about co-production. We've got a mutual outcome, which we were both there to achieve, and we did it successfully. My shoulder now is as it was before. She was engaging. She absolutely brilliant patient-centered care, excellent communication skills, professionality. So I asked an unrelated question about something different, and she explained in very nicely that she could only treat me for the condition that I've been referred for, which was brilliant. And I told her she was a credit to the trust, because I had 2 follow-up appointments. One was all around range of movement, and the second was strengthening exercises with a resistant band. She demonstrated everything for me. She adapted the exercises for my needs. And when I was a little bit, well, not despondent, but I wasn't sure there'd been any change, she'd done a measurement of the range of movement, and she told me, yes, that there was, which was great. And I felt, when I came out of there the first time, so proud. What a lovely human being. I was humbled, reassured. I've had a lot of patient experience over the years, and I can't remember for a long, long time an interaction or assessment or working with a health professional like that. And I'd said to her, you could train other people. There's a lot of people that could learn. I just go on, I'm so passionate about it, and I just could shout from the hilltops. And I put it through IQVIA as a compliment. I told her, and I've always visualised my mum, who's 89, going in for an assessment, and this young person would be absolutely brilliant with her. And that's really my shoulder is back to normal, which, I'm thrilled about. So thank you. And the trust, I'm so passionate. You can say I'm passionate about the trust, and I really, I don't know. I just praise everybody for the hard work they do whenever I'm involved in anything. Thank you.
Thank you, Sue. Oh my goodness. The only word that comes to mind completely is inspirational. You yourself, and to hear all that, and the work you do behind the scenes too, incredible. But I get very passionate too. But I'm going to stop and allow colleagues to come in. And if it's okay with you and Anne and Tracy, people may have a few comments and questions if that's okay. But I'll come back to you just at the end if that's okay. That's brilliant. Thank you.
Thank you.
Okay, so
thank you.
You've obviously stimulated a flurry of interest, which is great. All good, all good. Scott, can I bring you in first?
Yeah, I mean, first of all, thank you, Tracy, and thank you, Sue. Sue, that was an absolute privilege to listen to. I mean, obviously, from my perspective, I'm sorry that you went through the pain in the first place for your shoulder injury. But I'm now that I know that we're all being evaluated by you, I'm going to try and do my absolute best, right, to make sure that I can demonstrate the sort of aspects of compassionate and active listening. But I think you've absolutely put your finger on it. So you've nailed it about the things that are so important to us as an organisation. I think the way that you've given us that feedback there is almost like a textbook on how to do it. and that's incredibly valuable for us as a board. So genuinely thank you for the detail. It was balanced, it was detailed, supported by examples, intelligent, articulate throughout. So that was an absolute privilege to listen to. I genuinely mean that, right? And you know, if anybody can live up to the title of being a sort of, you know, a sort of random sort of reviewer as we go through it, and then Sue, I think we would always welcome it being you, because I think we know we would get a true response. So thank you for that. I'm genuinely glad to hear that your shoulder is better again. But you know, absolutely, the way that you've taken us through that was genuinely, you know, an important thing to hear, and thank you for the quality of the feedback.
Thank you. It's been a privilege to do it.
Thank you, Scott. We'll move on. I think Angela would like to come in as well. Thank you, Angela.
Yeah, thanks, Tracy and Sue. A lot in that. So a few comments, reflections, and some questions, if I may. So, but really thank you for sharing the story, the staff story, the journey, but also your story, Sue. It was incredible. Tracy, just in terms of the slot utilisation, that struck me as something that was really powerful for us to use further across the trust in terms of some of that learning. Paul's doing a lot of work thinking about productivity, and this is going to be incredibly important for us in this next period. So I just wonder whether we could do something to share more about that as Senior Leadership Forum, just to understand where that could be applied potentially elsewhere. My second point was around the vacancies being filled. That's incredible. Really pleased to hear about that and the journey of the team. But I'd be interested in your reflections. Do the team feel proud of what they've done? Is that coming across? Do they feel valued for what they've done? So I'd be interested in your thoughts on that. And then Sue, can I say thank you for everything you're doing for the trust, because you know, I wouldn't want to miss an opportunity to be doing that. It's incredible. We are indebted to people like yourselves and to you, and to thank you for being you, because as Scott's already said, that was very inspiring and you know, very emotional in the sense of what you're doing and what you're giving. Really, that's the important thing. You're really giving. But what struck me in what you described, Sue, was this sense of when you were recognised for your own expertise. That was so important, and I think that's a gem that we need to just make sure we're capturing. And can we do more of that learning in the organisation? Because I totally understand that. I've got a daughter who's a type 1 diabetic, and she talks about this. People don't always recognise that expertise, and I'm really keen to see if we can use your knowledge and experience in how that made you feel, how that was compassionate, to make sure that we're doing that across the board. But thank you very much indeed.
Thank you, Angela. Yes, thank you very much. No, it's a privilege to. Yeah, can't say it in words.
Thanks, Angela. If you can bear with us, we've got another couple of comments, Sue. So I think people are keen to comment. So I'm just going to bring in Krishni, our chair. Thank you.
Thank you, Julia. Actually, I think it's all been said, so I'm not going to repeat it. I mean, I you know, there's so many really important points that Scott and Angela have already made. And the thing that also struck me was that sense of equal partnership between yourself and the healthcare professional. That feels really important. I absolutely echo what Angela's said, because I think that sense of you know, yeah, just equality in the relationship and your chance to, you know, kind of contribute what you know, just feels really, really important. So I would absolutely support that. And the only thing, Tracy, that I wanted to add really was just whether there's an opportunity to use the quality awards to recognise any of what the work that's been done.
Yeah, absolutely. Sue felt really strongly about this, so much so that she did the Equivia feedback, and she also rang me the day after to tell me she'd done the Equivia feedback and to let me know personally about this. So I did pop down to see Aisha, who's the practitioner that she saw, and gave her that feedback directly, because I was here at the time. And we are going to be nominating her for a patient choice.
Yeah,
lovely.
Absolutely.
Thanks, Krishni. That's brilliant. Can I bring in David Williams, please?
Thank you, Julia. Thanks, Sue. Really helpful. And I just thought I'd draw out one thing that you mentioned for the board and just some of the things we're thinking about. Your support to University of Northampton and supporting the training of people coming into healthcare, I think is another really good example of partnership working. And it's one of those other things that we're really, really keen to develop, building compassion right from the very start of people's training. And we've got some meetings coming up with the University of Northampton over the next couple of months about what more we can do that builds that way of working. So thank you for highlighting that as part of the work that you do and in your story. It's been really good to bring that out today.
Thank you. Yes, yes. I mean, I really enjoy the work I do with the trust and the university, and as you say, to work together, because the university, they're producing some fantastic students. So, you know, they're coming out into the workplace, and it's about holding on to them, grabbing them, holding on to them, keeping them. That's what another passion of mine is. So that's brilliant to hear. Thank you.
Thank you, Sue. So I'm going to take a couple of comments from Tim, and then Anne, if it's okay with you, I'll bring Jo in and then finish with you, if that's okay, because we'll come to the end of our time, I think. So Tim and then Jo, please.
Tracy and Sue, thank you both so much. Sue in particular, I thought your passion came through. And you did what was brilliant for Mystery Shopper is you spoke about what people often keep quiet about. So thank you very much. Tracy, I love the work on utilisation and the slot utilisation and the work you've done to drive that, because that's so vital. We did a piece of work in Cambridge quite recently where we looked at the difference between poor and good performance from primary care and their rate of referral, because different PCNs and practices had used the additional roles scheme in different ways. Some had not got any first contact physios or podiatry, others had. And it's just another angle to look at it from. And I'm just offering it as we saw such a difference and it freed up so much more, which allowed then to accelerate. So just an observation of thought from primary care, that was all. But thank you.
We are thinking along those lines because we're doing quite a lot of work with spinal pathway as well, and the quality of the referrals varies even more in the specialist pathway. So yeah, there's a sort of system NHFT piece of work that's going on there.
Thanks, Tracy. Thank you, Tim. And Jo, last comment, if that's okay.
Thank you very much. Thank you, Tracy and Sue. I won't repeat and shower you with even more praise, but just a reflection really for particularly for the executive team, which is how do we share back into the broader system some of the patient experiences that we get to hear about? Because obviously there is a system dynamic that we're responding to very positively, but our partners may need a little bit of help in responding equally as positively. So I'm not expecting answers, but I think it's just something for us to reflect on how we do that. But thank you, Sue and Tracy, very much.
Thanks, Jo. Really important. And I think Angela's just going to come back in on that point.
Yeah, just important. I mean, it's a really important point, Jo. And I think one of the ways we can do that is through some of the collaboratives that we're involved in, because that very much is involving co-production, people's lived experience. They're system collaborative, so that does give that opportunity. But I think we'll give some further thought in terms of other ways we can do it in terms across all of the patient cohorts, because as you say, it's really important to us that we can influence others to using this experience. Thanks, Jo.
Thanks, Angela.
Thank you, Angela. Really important. And finally, Linda. Thank you.
Thank you very much, Julia, and good morning, Sue. Thank you very much for sharing that with us. And of course, I always enjoy speaking to you, Sue. I think just to respond to what Jo has said, so in the system quality committee that we attended that with Julia, we can actually ask Sue if you're happy to share that as a patient story, because that covers a wider breadth of system partners. And just listening to you, I'd already made a note to then get in touch with you, Sue, to ask you. And then Jo raised the question. So we can do that if you're happy to then share across our system.
Absolutely. If I can help in any way,
Thank you.
That's fine.
Thank you, Linda. Really, really important point. Thank you, Sue. And do you need a comment before I close?
Yeah, very briefly, just to say, the team have worked incredibly hard, and all the services worked incredibly hard, and they sort of after COVID. And I think seeing their progress, which was such a huge mountain to climb, has been phenomenal. And they seem really energized, and they should be incredibly proud of the work they do. Just in relation to the co-production, myself and Sue were invited to go and talk about co-production when the collaborative started in the system. And what's amazing is Sue doesn't let anything go. She just keeps going and gets into forums and has an amazing knack of just engaging people. So we will continue to foster that in lots of different places. But thank you, Sue, for all of that work.
Thank you very much. No, thank you, everybody. I've got worse. That's the thing. I think the older you get, the more confidence you have, and the more you want to speak out about things that are close to your heart, and that's what's happened with me. But thank you, everybody, for the privilege of being here today and being able to share that story, because we needed to be heard.
Thank you, Sue. I'm just going to wrap up just to say thank you to not only to yourself, but also, because that's very brave to come along and talk. I know you're very articulate, but actually to come and share it with a whole group of people that we don't know. And I just wanted to say that actually it's really important. We learn when things go well. We often hear about when things don't go so well, and we try and learn and spread that learning, but it's equally as important, exactly what you said about how do we then share more widely the experience you've had. So thank you so much for that. And also, and Tracy, to take back to the team, I've seen in the last couple of years some of the challenges and issues that you've had as a team, and to hear that the staff are motivated, engaged and enthused is incredible. And I think we've got lots of points here to take away, and I know there'll be lots of people behind the scenes taking forward, and that's the power of sharing, and it's great to hear from you. So thank you, Tracy, and particularly Sue, absolutely inspirational, and you set the tone for the rest of our meeting. Thank you so much for joining us.
Yeah, no, that's great.
You're welcome to stay with us if you want to. If not, you're welcome to leave us. But as I say, you're welcome to stay.
I might stay for a short time and pop out. I might drop out in a short time. But thank you. It's a privilege, and you're all doing an amazing job.
Thank you, Sue. Thanks, everybody. Great.
Bye. Bye.
Thank you. Okay. I'm afraid we have to move on, much as it pains me to move on from that really, really fascinating insight into our services. We're moving on to our risk section, and it's our risk report with Richard, Director of Corporate Governance. Thanks, Richard.
Thanks, Julia. Gosh, yes, how do I follow that one with our risk report? Well, I'll give it a go. So I'll refer to paper D in the pack, and we'll, as usual, take this as read. So I'll just draw out 3 points in particular before then taking any comments and questions. So the first point I wanted to raise is that this is the last report in the current format. So we've been doing quite a bit of work on transforming our risk management arrangements over the past couple of years, really, and board members will recall at the workshop we've discussed adding some extra information into reports to strengthen the assurance coming through to board and indeed to committees in support of our risk reports. So for the next meeting, we will be then seeing much more textured information about controls, gaps, actions and assurances flowing through, and that will hopefully bring us into line with the approach that LPT, our group model partners, are using as well, which will enable us to have a much more straightforward conversation about risk right across the group as well as within the organisation. So hopefully that's a really positive development. The second area then is in relation to our risk appetite statement. Again, board members will be aware that we've deferred our annual review of the risk appetite statement in light of the timeframes for the planning process. We felt it was more appropriate to wait until we've got clarity on the 24-25 objectives, which I believe are coming up later on our agenda, before we then did our annual risk appetite review. So of course we'll be scheduling in the opportunity for the board to reflect on risk appetite over the next couple of months, and I would hope that that would then flow into a future board meeting accordingly. And then finally, perhaps most importantly, the report, of course, provides the latest position on the assessment of our risks and progress against risk management plans. So reflecting on the actions in the action sheet earlier on, you'll note that the executive team has indeed reviewed the scoring of the Innovate objective, and also the way in which the data risk, so BAF 7, I believe, is articulated, and we are then, as the work on our data and digital agenda is transitioning, we're also then looking to reprofile the articulation of the risk to reflect the next phase of work. So I think with that, Julia, rather than going through the details of the individual risk assessments, I'll perhaps hand back to you for any questions or comments. Thanks very much.
Thank you, Richard. I just want to acknowledge publicly the huge amount of work that's gone on behind the scenes in the last year, particularly to bring it to this point, and to yourself, to your teams and others, and the executive team for getting it to the state it's in today, which is really fantastic. So thank you for that. And you've asked us to consider current risks, the risk appetite statement, and if we have any further assurance required. So I'll open it up to comments and questions from colleagues. Thank you. Anybody wants to comment particularly? It's a really full, clear report. Angela, thank you.
Yeah, I think, again, just to sort of reflect what's been said, but just to put my support to that, I think it really has been quite a journey and good piece of work. The development sessions have been significant in shaping and co-producing this. So it feels in a good place, and I feel that we're going to be in a much clearer place going forward, and that ability to consider those risks, those strategic risks, is very clearly there. So I would want to echo the thanks to everybody for taking this forward, and look forward to it being used in our next year. Thank you.
Angela and Saqib.
Thank you. I was just reflecting on our relative risk scores after mitigation. So, for example, I was considering finance after mitigation at 16 on BAF 6 versus others that are, say, still at 20. And so whilst we assess each risk independently, I'm just wondering whether the relative position perhaps needs to be considered in that. Obviously, finance, as we know, is one of our highest ones currently. So that was just something that came out and stood out for me.
Thanks, Saqib. I don't know whether Paul or Richard, you'd like to come in just to comment on that? Richard.
Thanks, Julia. Yes, so I guess first, from a technical perspective, Saqib, the scores are of course based on our risk matrix. So to a certain extent, they are an absolute score based on the requirements in the risk matrix. And I think you're right. I think we had a conversation at a previous board meeting about relativity and actually just understanding that, you know, almost as a sense check, really, actually, if this is the score here, does it make sense in the context of what else we're doing? And the other conversation that we're particularly having actually in relation to some of our significant operational risks is what level of risk we can tolerate. As you rightly articulate, we are still in a relatively high position with some of our risks on the BAF, which I think is reflective of the broader operating environment that we're operating within. And we are now more carefully considering actually the extent to which we can tolerate risks of that nature for a period of time, and indeed whether that would precipitate different choices or different moves. That's certainly a very active conversation that's happening within the executive team at the moment, and I think it's a point well made actually that we can consider again, particularly as we review our risk appetite statement, I would suggest, as we move into 24-25. Thanks very much.
Thank you. That's great, Richard. And David Williams has put a comment also in the chat about how they talked about other risks impacting on finance. So thank you for that, David. That really helps. Are you content with that, Saqib? Is that okay? Yep, great. Thank you for that. Okay, so we'll take the paper and note.
Julia, you've got Chris showing to speak.
Oh, sorry, Chris. I've just spied you. Thank you, Chris.
It was just to add into that conversation, say with the two workforce risks 3 and 4, Richard's point in the exec team, both the resourcing and the well-being, obviously we know they're some of the highest risks, but we've discussed it's timely to have, you know, a review of those through the groups and exec, because we are doing so much work in those areas. Do they continue to be, you know, the external challenges have been so great, but should they continue at that level? So it's to flag that point about relativity, that we are actively considering it.
Thank you, Chris. Really important to note that. Thank you. If there's no other comments, thank you very much, Richard. We'll move on to the system-wide winter planning and risks update from Anne as Chief Operating Officer, if that's okay.
Okay, so as we draw to the end of March, it's continued to feel very wintry-like within our system, and particularly in urgent care. We've sat most of this month at an Opal 3 on the Opal status ratings, but we've at many times had to veer into actions of an Opal 4, just showing that in that sort of intense. We're very near to pressure a lot of the time as an overall system. Now, we've done a lot of work to understand what that's about, and sometimes that's been around increasing COVID in our acute hospitals, or norovirus and things where they've had to make particular IPC decisions, but there's no specific outlying number one risk that we can sort of piece that on. So we are doing a further review of winter to understand that some more. We do daily submissions on our performance rates from ED, which I think is really helpful, although of course an added pressure is really helpful to see where we're tracking. And you can see that a lot of the time we are holding the line really very well as a system, but we have blips, and it's understanding the rationales behind those. We had an NHSE meeting this week around urgent care flow and discharge processes, which went, the ITB wrote to us today, went very well. And we were able to feed back about the initiatives and the things that we're doing in the community to support flow, and the importance of that. And actually, they noted at the end that it was actually much more around community social care discussion and developments that we were talking about as a system, which is really quite positive. So we hold that well, but we await further feedback from NHS England. It always feels like Easter comes so quick, but we are planned for Easter and the bank holiday weekend. We have everything ready. We've had a number of MAID events, which are discharge events in all of the hospital environments, including our own. And we're in a position to take on the 4-day weekend. So I think it's, as we said earlier on, the staff have been done an amazing job across all of our frontline systems, and I think the relationship is really very, very good in that sense, and I see that as an ongoing development from last year, and that can only be very positive in the tough times. I think that's about it in urgent care at the moment.
Thanks, Anne. I'll open it up in a sec, but I think what your summary just reminds us of the constant pressures and challenges that our staff face on a daily basis. And we've heard in previous boards about the huge amount of work behind the scenes to try and improve things for patient service users and staff. And I feel very assured by the extensive planning that goes on, and we see that through the committee structures throughout the organisation. So again, huge thanks back to all the teams for their continued kindness, compassion to people in very difficult times. Anybody got any comments or questions for Anne particularly? No? Okay, thank you very much. Thanks, Anne. And we'll just take in this section the last paper, which is paper E, which is our Alert, Advise and Assure report from the Integrated Assurance Committee, which was you did this time as Deputy Chair.
Thank you, Julia. Good morning, everybody. Yes, I did have the pleasure of chairing the IAC the last occasion. I will take the report as read. There are just a couple of points I wanted to highlight to the board this morning. Firstly, our deep dive on the last occasion of the IAC was in relation to our BAF1, which concerns our collaboratives and partnerships. We received a snapshot of NHFT's many and very varied partners across the NHS third sector, public and private sectors, as well as where we are with collaboratives. We had a quite detailed discussion around the complexities of working with partners and what lessons we have learned from that. And we received strong assurance on the value that our partnership and collaborative work is bringing to teams, the benefit to patients, and the work that is currently being done to deliver a structured strategy for our third sector partnerships to ensure that there are clear deliverables and positive outcomes. So that item, deep dive item, was rated as assured by the committee. Now, the advise section, the items that fall under there, I'll just briefly run through those. In relation to our BAF, I think the assure is related to the ongoing work that the BAF is still, if you like, in involvement. which also, and it also reflects the fact that the grow aspects of our BAF are, if you like, not so much risky, but they are very much highlighted to us. It's which to do with our workforce. So the workforce dashboard report, where we specifically focused on three things, which is turnover, annual appraisals, absence and sickness. For turnover, we looked quite carefully about the Northamptonshire employment market, which has such a direct impact on the turnover rates for the trust. For appraisals, we were assured that there is a lot more focus. There's a more focused view on individual directorates and team leaders delivering annual appraisals, so those rates should improve. And for absence and sickness, there was a deep dive which was carried out by the Wellbeing Steering Committee. So we gained assurance from that. And finally, the agency spend report, although there was good news around an assurance received around the strong grip and control, as evidenced by our continued reduction in agency spend, there continue to be challenges, and therefore the report and this aspect of the work remains under advice. And we also discussed the likely stretch targets that we're going to be having to meet in the 24-25 year. I will leave the other aspects of the Assure report as read, but really happy to answer any questions that anybody has on that report. Thank you.
So you did really comprehensive summary. Can I just open it up if anybody has any comments or questions? Report. I think there's quite a significant number of us on the call who are actually at the meeting, because it's a mixture of performance and quality folk. So there's nothing particular. Oh, Krishni. Thank you.
A brief comment, Julia. Obviously, I don't attend that committee, but it's always good to see. I mean, the agency spend is such a big focus, isn't it? So I just really wanted to commend colleagues that we have, you know, that positive news, because it's such an important area of focus. We recognise that agency spend is not just a financial issue, but a quality issue as well, and therefore, you know, the controls we've put in place are clearly proving to be effective, and we just need to maintain that. So I just really wanted to acknowledge the work that's obviously gone in to achieve that position, because unfortunately across the country, I don't think that's always the case across all organisations. So it's really important that we maintain that focus. But thank you everyone for the work you've done on that.
Thank you, Krishni. Echo that completely. Angela.
Yeah, just to say again, in relation to the agency work and some of the, you know, concerns around some of the prison usage, just to say that in our national escalation meetings as a system with the National Finance Director, Paul and I have been able to, you know, obviously explain that particular area for us, which has been understood. And certainly I think important to share that in that last national meeting, the National Director was very clear about the progress that had happened around our agency position. You know, he spoke about that specifically in the meeting, in the system meeting, which I think also reinforces and provides some assurance that that's understood by NHS England too. Thank you.
Thanks, Krishni. Really important for us all to hear that, I think. So thank you for that. Okay, no other comments or questions. Thanks again, Judith, for the report. We'll move into our strategy section, which starts off with Angela giving us an update on environmental analysis, if that's okay. Thanks, Angela.
Yeah, thanks, Julia. Just a few things just to share with the board. So our Integrated Care Board is now embarking on some recruitment for the Chief Medical Officer role. People recall that there is an interim individual in place, Imogen Staveley, but it's going out to advert for that role, and the same with the Chief Nursing role with Yvonne retiring. So we look forward to hearing more about those. Again, I'm sure people will be aware that our neighbours, Nottinghamshire Healthcare, have a significant level of scrutiny upon them at the moment with a Section 48 review. They are one of our East Midlands Alliance partners, so we're staying close, supportive, and also will use it for any learning opportunity in NHFT and across the group, as you would expect. Looking into LLR as a system, which obviously our group partner LPT is within, just to say that the ICB chair role is also out to advert and is going to be recruited in April. So again, just to alert people to that, and the same for University Hospitals Northamptonshire and University Hospitals of Leicestershire have a shared chair role. That job is also out to advert. So again, encourage people if they've got any networks to share that with people. And I think again, just to also share from a group perspective, there has been a recent Children's Commissioner report, and I'm pleased to say that in LLR and LPT that has been a case study highlighted around the focus on waiting lists for children, young people, and the triage and navigation services, which I think also will give us really good opportunities for learning across the group. But I'll leave it there. Thanks, Jill.
Thanks, Angela. Really important. And going forward, thank you for keeping us close around the changes of people. It's all about people, isn't it? Our networking across systems, and we have some quite significant, important posts of people that we and the entire board liaise with on a regular basis. They're changing people, so look forward to building relationships with some of those new folk when they're in post. Anybody got any comments or questions for Angela? No, thank you very much for the update. Krishna, you're going to hand over to you for the chair's report, if that's okay.
Thank you, Julia. It does feel a little bit unusual not to be handing over to myself for that one, but there you go. I will take the report as read. I really just wanted to take the opportunity to highlight the priorities that the council identified, which I know many of you were at the last Council of Governors meeting, but I think it's really important to note that the council identified a selection of priorities which are obviously highlighted in the report, and I think it's really important that we support the council with those aspirations that they have, and we'll be, I know Richard and the team will be working to do that very closely. It is also appraisal time, so I just want to encourage everybody. I know there's a lot of feedback requests that are prompted, will be prompted or have been prompted already over the coming weeks, and really grateful if colleagues can take the time to provide that feedback, because I know it's very much valued by everybody. So the Evaluate system will issue out those requests as usual, and then we'll be concluding the process through the course of the next few weeks, and reporting to the Council of Governors, of course, with regard to appraisals, and particularly important this year because we have the new leadership framework, which whilst it particularly affects my appraisal, and the changes to the appraisal framework for chairs generally, we're asked to consider it in the context of all appraisals, really, because that's part of the fit and proper persons test or framework that's being introduced. And I will come back to that actually, because that's an additional point I'd like to make. But I also want to just recognise, having mentioned the Council of Governors, that a number of our governors, as we mentioned at the council, are standing down, and we thank them hugely for the work that they've done and the support they've given us as a trust. We have had a fair amount of interest in our vacant seats as well, and we're looking forward to an induction event, a face-to-face induction event, which I know a lot of NED colleagues will be supporting in May to welcome new council members. So that's going to be very exciting. And then just going back to the fit and proper persons test, Richard, I know Richard and the team have been working to conclude the sort of initial phase of the new requirements. I will be personally receiving an update on that later, and we will be reporting to our nominations and remuneration committees on the conclusions of that very shortly. So I just wanted that to be noted, because the first phase of that is due to be completed at the end of this month. And then finally, just wanted to echo again my thanks to Scott. Scott, I think you're going to hear those thanks repeatedly over the coming meetings, but it is a public board, and you know, I think you're probably the longest, well, you are the longest serving NED now on our board. and one of the first NEDs that I recruited. So I really, my personal thanks to all for all your support over the last 7 or so years. I think nearly 7 years now. It's been a ride, I think you would probably agree, and I just want to say thank you, and that won't be the last time, I'm sure, but I think it's important for me to express that in public. So thank you, Scott, and back to you, Julia.
Thank you, Krishni. Yes, echo that again, Scott, but also just to note your last points on the paper, contributing to feedback, etc. Yes, please, folks, getting involved, and to echo your comments about the contribution of governors. And I definitely look forward with colleagues to the induction session. We had a brilliant one last year, and we've recruited some new governors, so look forward to the next one. Has anybody got any comments or questions for Krishni? Particularly, Joe.
There's just a few gaps, Julia, in Appendix A. So, Krishni, it's not for you, but I'll make sure that Jane has the details just so that we have a full record. But I'll do that separately. Thank you.
Perfect. Thanks, Joe. Yes, actually, I'm glad you mentioned the appendix because it does outline all the activity of the NEDs and Krishni, and it's really important that people see that our contributions. That's really great. Thank you for that. Okay, Angela, over to you for your Chief Exec report, paper G, please.
Thanks, Julia. And I just want to start. I know we've had a few thank yous already for staff from Julia and Anne, but I think, again, really important that that I'm expressing our thanks to all our staff across the organisation. You know, people have mentioned pressures. Those pressures are there, whether we're clinical or non-clinical services, and people are still going above and beyond. And that's with continued industrial action too. So again, I think really important just to acknowledge them and thank them for everything that they're doing every single day. So just a few things that I wanted to highlight, and I hope people have noticed some of the innovation in the report this time, and in particular really pleased to be sharing the menopause support for women in custody. This is just, I think, a fantastic example. It really will, I'm sure, make a difference for people, and the fact that we're doing that here locally, I think others will learn from. So really pleased to see that, and I'm sure others will want to hear more about that in due course. And similarly, in relation to the symptoms of depression, and looking at how we can innovate continually with our research team, looking at the Flow headset. Again, let's watch this one with interest, but I think, you know, really encouraged. I know ITI is doing a lot of work around the innovation space. There's lots more still to come from this, and I think we've really got a lot of energy building and continuing to take innovation forward. So really encouraged by that. I also just want to highlight David's role as the NHS Providers Network Chair for strategy leads. This is NHS Providers, just to remind people, is a national body representing all provider organisations. It has a lot of influence. It's a really important body. I've sat on the board of it before and achieved a lot of development and opportunity through that. I'm really pleased that David's been voted in as peers to that network chair of strategy directors. It's really important because I think I know that David will get development out of that, and it's well done to him, and I know he'll use the opportunity well, but it's also the influence of community and mental health into that strategy place, which I think is really one that I would also want to bring everybody's attention to. So well done, David, that's fantastic. And then last but not least, I can't not mention Meadowbank. You know, the accreditation that has been achieved there, you know, it is fantastic. People take great pride in this work, and rightly so, and we feel very proud of them. But you know, achieving these quality indicators is a lot of work. So it looks like, you know, a small reference in the report, but there's a lot of work that goes on. I saw the photos of the team, and I know the media's covered this, but this is just a real accolade for them, and obviously for the patient care that it affects. So thank you to them, and hopefully that encourages others to also aspire to those quality measures. Thanks, Julia.
Thanks, Angela. Really, really important things that you brought out there. And the innovation, the Flow headsets, was actually on the national news and in the local news earlier this week. So that's fantastic. And thank you, ITI, for leading the group around that. And yes, thank you, David, for your continued efforts in the partnership space. Has anybody got any questions or comments on Angela's paper?
And Julie, just while people are thinking in case there's anything, but because I know I'm conscious I'm leaving before, can I just indulge and not miss the opportunity to say thank you to Scott, please, because I won't be here when you're doing that at the end, so apologies, but I can only say thank you so much, Scott, for everything you've contributed towards NHFT. It's obviously been quite a significant part of my journey as chief exec, and it's really been great to have you with us. You've achieved so much with us that I don't think I've quite realised that you're not going to be with us yet. So thank you very much. And as I say, as Christian said, it won't be the final time, but I didn't want to miss that public opportunity. It really has made a big difference. Thank you.
Thank you, Angela. Echo that again. Thank you. Melanie and Joe, thank you. So Melanie first.
Well, I was just wondering whether we should have a vote on just locking Scott in a cupboard so he can't actually leave. But aside from that, I also had just a comment really on great to see the charity donation enabling the garden at Isbrook. And it kind of just triggered my thinking that we had a lot of focus on the charity. Was it last year or the year before? I lose track of time. I know the charity has kind of got itself into a whole new position. And I think whether at the board meeting or maybe at one of the committees, it might just be timely to just have a bit of a refresh with how's the charity doing, you know, all the good things that the charity is doing to support our trust. And I'd welcome just an up-to-date understanding of you know, the function of the charity and how it is helping us. So as I say, through the appropriate committee, maybe Richard, you can have a think about how we might bring that in, because the charity, you know, it covers lots and lots of our different functions, doesn't it, or can do in its donations. So just a request really to consider how we might do that.
And I think, Melanie, obviously we've got an update today on the agenda, so there will be obviously that opportunity. Dave will be presenting that, and I think Jonathan McGee is also attending, so we've got that opportunity as well. You're absolutely right.
You're absolutely right. I missed that completely. I don't know where my head is. Sorry. Thank you.
No, good reminder. Good reminder. Thank you. Was your comment on the similar vein? No. Okay. Joe, please.
Thanks, Angela. I was just going to pull out the anti-racism programme launch. There was a number of us attended a Midland non-exec briefing around patient and carer race equality framework, and obviously, you know, it's a statutory requirement from April, but fundamentally, it's part of our core values. And it's something we've been working on for a long time. It's not just about culturally appropriate advocacy and choices, it's much, much more substantial than that. And it's just to make sure that we as a board keep our eye on this, because it is something that's, you know, literally is at the heart of the way that we work. So, yeah, just to highlight that. Thank you.
Yeah, absolutely, Joe, and very confident that we are taking those steps, and we take it all very seriously, as you know, and that's why we've got a group priority around Together Against Racism, but also the work that you describe is being taken forward in the trust, and, you know, I can provide assurance on that.
Thanks, Angela. Really important response. Thank you. Anybody else, any questions? No? Thank you, Angela, for the report. We move on to the DIGBQ, that's our trust strategy objectives for the forthcoming year, paper H, and I think it's David. Thank you very much.
Lovely. Thank you, Julia. So just as a brief reminder, NHFT, we started with DIGBQ, develop, innovate, grow, build and quality as being the key part of our strategy, I think back in 2017. And then we've updated and revised the strategy from 2022 through to 2025. And one of the things we've been looking at this year is how do we really help ensure that we get clarity around the objectives and the goals that we want to deliver while retaining that focus on DIGBQ and the elements that are there. So we've worked through an exec conversation, and I think we also had the conversation in performance committee about the objectives and the ways forward. So they're brought here today for looking at. We've got kind of 5 key goals in DIGBQ, and we're proposing 6 key objectives for the year going ahead and finding a way of working things through. The 6 objectives we've done by linking to the BAF as well. to make sure that they all align and make a clarity of where we're going. And we think this will give us clarity for the financial year we're just about to go into, so the 24-25 financial year. And then also through joint working group and other bits of conversations, an engagement plan, then having a think about over the next 12 months what we have as a strategy going forward from the beginning of 2025. So the objectives here today are an opportunity for board approval of the way forward.
Thank you, David. Angela, I can see your hands up.
It might be Angela was about to say she needed Chris needs pointing chat.
Ah, yeah,
Yeah,
fire alarm's gone
so-
off. Oh, okay, so the chat.
Yeah, so
fire alarm's gone off.
unfortunately,
Yeah.
I think colleagues who will be at Berrywood will have had to have left the meeting again. I think we can continue for now in the hope that they will shortly be back, because I think we're probably fairly well represented. But please carry on, and then I think we can take stock and see if we need to break early, for example. Sorry to interrupt.
Thank
you.
Thank you. Thanks very much for that. Okay, so any comments or questions? Judith.
Thanks, Julia. Thanks, David, for the update. And as you mentioned, we did discuss this at Performance Committee. So it's part of the AAA report that that contains the discussions. I was also sort of reflecting since then. The separate pillars of our strategy, the DIGBQ elements, is the pillars. They actually all interrelate. So I was just wondering if in the objectives going forward, we can recognise that there is this overlap between our strategic pillars. Because, for instance, if I give you an example of innovation, that impacts on everything. On the other four, and I don't know if we are, if you like, reaping the benefit of that recognition. So we are actually achieving things under our individual pillars, but we don't necessarily track that under innovation, let's say. So I don't know if that's making sense, but I think it would be really useful just to give it some thought as to how we can recognise what we have achieved, and also how to set ourselves some stretch targets for the remainder of the strategy. Thanks, David.
Thank you. Did you want to come back on that at all?
I didn't know whether building Melanie's point and then try and come back as a summary, would that be helpful?
Yeah, that would be really helpful. Thank you. Yeah, Melanie, do you want to come in?
Yeah, so apologies as I wasn't at Performance Committee, but I was just reflecting on as a strategy, and I understand this is at a strategic level, the objectives are at very high level and strategic, and there is a myriad of information and specifics falling under this within the actual operational plan. But I wondered whether there had been a discussion at Performance Committee about the lack of reference to financial performance above and beyond the reference to the value programme in the build section. And no other real reference to the financial challenge, returning to break even, and the very strong focus in this next financial year about recovering our financial performance, which may be at the next level down, and not necessarily at the strategic level. But I just thought, given the critical focus on financial performance from our stakeholders and the very clear messaging from NHSE, it didn't seem to play a particularly large part.
It's fine. I think I can pick up both, and then if colleagues want to add anything, feel free. So I think Judith, the challenge about sort of pillars and connections is always one of those evident bits. And I think what we try and always do is draw out the conversations about the examples of where things go and how things work through. I think as an exec team, we're very aware that developing partnership, while I might have the leadership for it, developing partnership is not mine, it's everybody's, and the same would apply for Innovate. And I think an example from our patient story earlier today about the connection around growing our workforce capability, the University of Northampton, and also the conversations I'll have with them about partnership work sort of brings together Chris, Linda, myself, the portfolios, and trying to connect the stuff in. So I think we always try, although we've got compartments for the work, we work incredibly hard to demonstrate they're not silos, and ways of bringing that together. I think, Melanie, on the finance and our response around finance, one of the things that we've been really keen to do is to recognise that the change for NHFT is in really good quality care, delivering efficiency and productivity, and we're not, and through that comes our financial challenge. And we've been really clear about taking the quality, value, productivity approach and being really public about this is how we're going to change the organisation, rather than an approach which is this is the money, we now change the organisation to fit the money. So I think that's why it looks different in a way of going forward.
I guess my response to that would simply be that I absolutely understand that to look after the pounds and the pennies look after themselves sort of things. And, you know, all of the strategies that we're pursuing will result in a positive impact on our bottom line. I guess it's just it doesn't come out implicitly. There is no sort of implicit recognition of the benefit to our financial position from all the work that we're doing, and I just wonder, in essence, you know, whether there should be a more explicit sort of link to make it absolutely clear that that is a key part of our strategy, is doing this stuff in order to, and as a side effect, if you like, of the financial stability it will give us, because we know that there is so much to be gained from having strong financial stability. So much that we want to build depends on strong financial ability in retaining our segment 1 position, and etc. etc. So, you know, I as I say, I wonder whether the performance committee had a discussion on that, but it was just a reflection to take into account.
And Melanie, David, could I bring in Paul and then Krishni, because I think they're going to contribute to that, and then we'll wind this one up. Thank you. Oh, Krishni, I think Paul's put his hand down. Krishni.
Oh, thank you, Julia. I was just going to say, I mean, I think it's a difficult one, isn't it? I completely understand Melanie's point. I think there's just something about, for me, I don't know, I wonder whether the focus is about finance versus just broader, that sense of sustainability and value for money, and, you know, those sorts of principles, because in the end, the finance plan is a given. I mean, to achieve our, you know, there are so many givens, and we could reflect all the givens in our strategy, but in a sense that it seemed to me kind of that broader issue about sustainability, which brings in a whole set of other things, which include finance, actually. Just feels important. But more specifically, I was going to say, I just wondered how the feedback from the performance committee was being taken forward, because I think in any case, the performance committee report highlights prevention and more measurement as the key things, and one of the outcomes might be, you know, this year's financial plan. And so that was sort of one of the questions I just really wanted to pose. Thank you.
Thanks, Krishni. I'll bring in Paul and David, and then we'll see if we get some responses to that. Thank you.
And Julia, I think, you know, just picking up on Melanie's point, and Krishni's touched on it a bit there, I think we, you know, on reflection, we can draw out a little more about the relationship between the value programme and the overall financial position. I do think there is a difference, though, between what we're trying to achieve through here in 24-25, and I get the linkages to break even, but actually we need to be more, I think it's more nuanced than that, and I think we need to bring that out in terms of the linkages between the value programme. And to put that another way, Julia, break even doesn't mean to say that we've achieved everything. Break even might be compromising safety, it might be compromising all sorts of quality issues or service delivery. So I think we'll see that in the round. It's very difficult at this stage, given the fact that the operating plan was only released last night, to sort of to see how that impacts on the financial plan for 24-25. So there is a difference there, and I think we just need to sort of draw out and reflect on Melanie's point, how we make that clear in the statement that we've got.
Thanks, Paul. And actually, both David and Joe have put in the comments. The suggestion is that it's included in the "this includes" column in build. So I think that sounds a really good suggestion. Thank you. And Melanie's put in the chat, agree, Paul, the strategy shouldn't be break even, but achieving financial stability. Absolutely right. Thanks, Melanie. Just bring in David before we close this one. Thank you.
Thanks, Julia. I mean, helpful discussion. I think just the antecedents for the value programme was around value in healthcare. So value for patients, value for staff, and value for the taxpayer. And I think we could probably enshrine some of that. We talk about social value, but I think there's probably a bit where we can include that triad of value for patients, value for staff, and value for taxpayer, because that is what we're doing through the value programme.
Thanks, Dave. And we'll take note of everybody's points and build that into the refresh going forward. Thank you. Okay, if there's no more comments on that, I'm going to move into our last section before our break. And just to welcome Jonathan McGee from the Northampton Health Charity Fund. Just to say that apologies, Jonathan, that we've kept you waiting. I know we've not met, but hello, I'm Julia Curtis, Deputy Chair, and I'm chairing today. Krishni is here on screen, but I'm chairing. And we've had a couple of fire alarms go off at our main Berrywood site, so people have gone in and out. So apologies, we are running slightly late, but we've allowed a good 25 minutes for this really important discussion and debate. So I'm going to hand over to Dave Mayer to introduce this section, please, Dave. Thank you.
Thanks, Julia. I mean, I won't stand on ceremony with this. The charity's been around for a long time. We're very fortunate to have it. It's been referenced in Angela's report in terms of refurbing parts of our estate and putting outdoor spaces in for patients. It's also funded our Reflect and Reconnect days, which have been actually really critical post-COVID for getting teams back together, and I firmly believe have made a real important contribution to us sustaining really good staff surveys results in that sense by kind of really putting teams and people first. Jonathan's taken on, he'll speak for himself, but taken on Chief Exec role back in June. Judith and I are the trustees on behalf of the trust. We join a range of other trust partners, non-execs predominantly in that sense. And we've got a piece of work that Jonathan will talk about in terms of next steps in relation to the integrated care system and what the charity interface with that is and how that links with the strategy that no doubt Jonathan will also guide us through, or at least give us some headlines from. That's all I was going to say. Thanks, Julia, and welcome, Jonathan.
Thank you.
Over to you, Jonathan.
Thank you. Am I okay to share a presentation quickly? Yeah, thank you. Let me just
I can't see you, Jonathan. Can others?
Can you see my presentation at the moment?
We can see the presentation, but I can't see you. Can you see the presentation, everybody?
Yeah.
Yes.
Yes. Could go to full screen.
Yeah, just about to do that. Thank you.
Great.
Brilliant. Thank you, everyone. Today I'll just give you a brief sort of presentation on just a few things we've done for NHFT over the last financial year, and then I'll give you a brief overview of our strategy going into this new financial year, which is going to see some significant changes in the charity, but all for the sort of greater benefit of the trusts we represent. Just to give you some examples of the things that we funded. I mean, David mentioned about environments. So environments we know are really important to patient and user recovery and experience. And so we're pleased that we've been able to fund things such as the Hazelwood ward and having these enhanced and more welcoming spaces for people to either relax or to experience their rehabilitation through, and that's important in all sorts of settings. So we're also pleased to help refurb the Serenity room, because the environment you experience care in is really important in recovery, and we're looking at doing a lot more environmental enhancements across our trusts over the next few years. Again, the sensory rooms are really important in terms of mental health, and actually we're working with Tim Diggle at the moment to look at a sensory room appeal to go wider across NHFT, but also linking in with the other trusts who are looking for sensory rooms as well. So NGH are looking for a sensory room for A&E. So there's ways we can work together to deliver a sort of more integrated approach to the things that we can support for the trusts and for patients and users. Environments are really important, but also really important and the staff who deliver the care. The charity funded the Quality Awards last year, and we're pleased to announce that we're going to be able to fund the Quality Awards again this year. It's really important that staff are recognised for the above and beyond that they provide for the people under their care, and that's that's what the charity does. It funds the above and beyond that can be funded by the NHS. So yeah, so staff are really, really important. That's just a quick overview of some of the things that we've helped support NHFT with over the past year. I'm going to now come on to our new strategy, a brief overview. And this shows the direction we're going in to be able to raise even more money to do even more enhancements, such as the things I've just gone through. So with the new strategy, what we are aiming to do is double our annual income from 1.2 million average per year to 2.4 million a year by 2027. There's lots of things behind that, lots of changing the ways we're doing things. We're reaching out to more major donors, more grant providers, getting more corporate partnerships together. So that Quality Awards is also being part funded by Barratt Homes. We've got some strategic partnerships going on, so we're looking at significant increases in income. The other thing we'll be looking at is regular giving. We don't really do that in the charity at the moment. We're just about to, we've got a new head of fundraising starting in a week's time, and they've got a strong background in that regular giving, so we'll convert a lot of our supporters to regular givers, and that'll give us some sustainable income streams. We're also now, Alison McCulloch is now the head of charitable expenditure, so we've got a designated and focused role looking after charitable expenditure, so we'll be seeing some improvements across our charitable expenditure approach, which will also allow us to be more equitable in how we spend the money. We'll be making improvements in making it clear about what the charity will and won't fund, working with the trust to identify more strategic projects. We'll be moving the application process online, so there's lots of improvements around that charitable expenditure pathway. And also, one of the things we want to do is significantly increase the unrestricted income. At the moment, we have 250 funds across the trust, with all the money spread across those funds. And the problem with that is each fund doesn't have enough to do anything meaningful. There are a few funds that have got a lot that can do it, but a lot of the funds don't have enough to do the meaningful projects they want to do. So by encouraging unrestricted income, just general donations to the charity, it means we can help fund those things that otherwise are limited by the size of funds. But it also means we need to take a review of the funds and consolidate where possible. So we're identifying where there's overlaps of funds, where they could be merged strategically, and for NHFT we're working with Tim to identify what those funds are that we can merge. But effectively, rather than having a small 100% of a really small pot, we want people to access consolidated much bigger pots, so that if people have ideas, that the funding's there to enable them to be put in place. So the purpose of the new strategy is to increase income, like I've said, to work in collaboration across the trust. So rather than looking at things in silos, we have done before, to try and identify sort of where we can join up, fund more strategic items. That means we can go out to our supporters and say, here's the impact that we've created from your donations. And then we can use those stories to then recruit more donors, especially, like I said, the high value donors, and why they should support us ongoing, and then therefore that will lead to another increase in income. Just quickly, our strategic objectives for the next 3 years are: one, to generate the sustainable income, like I've said. So we want regular income, not ad hoc donations. The hardest thing is getting the donation in the first place, and then trying to get fresh donations in is really difficult. Getting regular donations and long-term support is much more effective. We want to support patient care pathways. So rather than, again, looking at ad hoc expenditure requests, we'll look at how they fit into a patient's pathway across the piece. And again, just reflecting on the funds consolidation in a typical hospital. I know NHFT is different, but in a typical hospital, a patient will see on average 17.8 healthcare professionals across all different services, whether that's the person who, the ambulance drivers from A&E, people in A&E, people doing pathology, bloods, the staff just on the wards, all through to when a patient exits and recovers. People see so many different people across a pathway that actually, when people give to a specific area, it means they're not recognizing the whole cohort of people involved in that care. So it's a bit like sharing tips that focus on unrestricted income. But the point is, we want to look at patient care pathways as a whole. We also recognise, as I've said earlier, that enhancing environments across the states is really important. So that's from improving areas to capital projects. As mentioned, the sensory rooms, that could be a cross-trust initiative. And also importantly, we need to look at staff wellbeing and development. And it's been all ad hoc at the moment, ad hoc expenditure requests for tiny things to big things. And we want to make it more unified across the trust. So there's a programme of works to support staff wellbeing development, and people understand what the charity can do, and how we can make a more strategic impact on staff wellbeing development. And then all that is enabled by working in collaboration, partnership with the trust. So one of the significant changes, and we're still working up the terms of reference for these for the new subcommittees, is we will gradually phase out the trust-based subcommittees and look at strategic subcommittees of patient pathway, environments and enhancements, and staff wellbeing and development. So those new subcommittees reflect the strategic objectives. You know, and I know you've got the acute trust, etc., and mental health, but physical health has a mental health impact, and vice versa. They're interlinked, and so that's why we're looking at these thematic subcommittees that can bring in experts from across trusts to input into reflecting on what the charity can spend. Just quickly, so you know, there's an opportunity to work with a charity to, if people have got ideas, they don't need to be based now on the balance of your fund. If people have got ideas and they want to think bigger on what the charity could help support those above and beyond NHS funding, there's an opportunity to chat to us and work out what those things are. Like, I'm labouring the point, but unrestricted funds mean that we can do so much more across the trust rather than being locked up in all these small funds. And also staff can take part. So we've got quite a few events coming up, and a quick plug for the Northampton 10K on the 26th of May. There's lots of spaces left. So if anyone wants to sign up, they can visit our website, northamptonshirehealthcharity.co.uk, and you don't have to run 10K. There are 5K options as well. So that's it from me from the presentation. So any questions, please?
Thanks, Jonathan. I wonder whether I just briefly offer Judith the opportunity as the other trustee, if there's anything particular you wanted to add before I bring in some others.
Julia, thanks very much. Yeah, thank you. And Jonathan, thanks very much for the presentation. I did, if I may very briefly just add a couple of things. From an NHFT perspective, I think I would really just like to thank the charity, well, Tim and Alison, who've been working with improving the process internally to NHFT to enable staff to make applications for funding and to make that more seamless, but also to comply more visibly with Charity Commission requirements. So that's been a real change, and I know that there is also a second most important thing there, and I've already referred to it. I think there is a work undergoing currently to draw together a strategy for all our third-party partnerships, and that will include Northamptonshire Health Charity, but also the other charities we work with. So that will also be a really useful framework for us to ensure that we are actually delivering change, which is really what charities and NHFT is all about. So yeah, those are the 2 points I wanted to add. Thank you.
Thanks, Judith. I'll bring in a couple of NID colleagues with their comments or questions. And Robin first, thanks.
Jonathan, thank you very much for your presentation, and lovely to meet you. Brief bit of declaration, really. My wife, one of the acutes, has received funding through the scheme for a project that she ran, so I ought to declare that. But as a 4-time chief executive of charities, you're commendably going down the unrestricted funding route and looking to develop more funding from a greater multiplicity of sources. But it's perhaps the most challenging time ever for charities to do that. How confident do you feel that you can increase your level of income to the figure you've identified, given the multiple challenges from the cost of living increases and so on, and the competition from other charities?
So that's a really good question. Thank you, Robin. So we have seen a decrease in income from I would say mass donations, which is one of the reasons we've restructured the charity slightly, and we'll be focusing on those higher value income streams. So Christina, who was looking after a bit of the mass fundraising, is now Christina Kelly is now the head of philanthropy and partnerships. So we're already seeing significant income coming in from those major, the higher value income streams, because they've got money. When we approach corporates, they've got budgets they can spend. It's almost like an advertising budget if they sponsor us for stuff, and we're working on those longer term partnerships. So we're focusing on where the money is, because getting it from mass is difficult. But that's one of the reasons we want to encourage that regular giving for those that can afford to give £3-5 a month. It doesn't take a lot to suddenly build that up, and then once we get people giving regularly, we can ask for second gifts, third gifts, for appeals, etc. We can start building our legacy pipeline as well. So we're looking at we're not doing anything different really to other charities in terms of looking at that sustainable income, but that's what we're looking at, that sustainable income. So we've got a bedrock to build on. Your other question was about competition from other charities. I mean, that's just how it is. It's always been that way. I think one of the key things we're conscious of is getting more presence across our trust, because if you walk into around the trust, we're not screaming the charities here. That is one of the things we've identified in our new strategy, to make ourselves really visible to the users of the trusts, to simply say, if you've had great care, say thank you and encourage donations. So we're focusing on the nearest, dearest, the warmest audience, really. That's where we will make inroads.
Thanks, Jonathan. Saqib.
Yeah, thanks for that presentation. As a CFO of a charity, then experience these things every day, and say the points that you're highlighting, especially on the unrestricted funds, of course, really important. Something that I just wanted to ask whether you've considered, obviously, wills and bequests you would be looking at already, but whether you've considered having people donate either shares or dividends, mobile phones and jewellery. I think there are various partnerships you can do that people send it off to the established partners, but then the funds come back to the charity. So just some other ideas.
Yeah, thank you. I think there's lots of opportunity for the charity to look into. I don't think we're there yet to look at the additional stuff. I want to get the fundamentals right. Like I said, we're getting a new head of fundraising starting next week, and just need to get some of those basics done. But then certainly we can look at things like shares and jewelry, etc. There's quite a few opportunities like that out there, and we will definitely look at things like that in time. And so if people have fundraising ideas, it's great. We can't do everything, and we have to pick where we're having to focus more on where the value is coming from.
Thanks.
But
Thanks, Jonathan. Thanks, Jonathan. I'm just going to bring in Joe and Itai and then round this off. Thank you. Joe?
Yes, thank you very much, Jonathan. Really good to meet you. Robin beat me to the challenge on the finance side. I'm a trustee of a charity and I know how really difficult it is. So you've set yourself some really big goals. My question is prompted from one of the examples you used on your slide deck, because if I'm not mistaken, the sensory room that you used was the one at the Warrens. And just from visiting that site and seeing how local people and volunteers and patients use and interact with that space is quite incredible. So I think, if there is some opportunity for that virtuous circle to be created in terms of the impact that your donations have on people's recovery, on support for family and friends, I think the point you made about being visible is really well made, because in my short time in Northamptonshire, I haven't seen that much visibility from the charity. So I would really strongly advocate promoting yourselves very visibly and shamelessly, because I think people will respond to it.
Thank you. And just a key thing to emphasise that is that the head of expenditure, actually their job title is head of expenditure and impact. So the key thing is getting those impact stories and reports into the comms team to be able to get out there. And yes, visibility is a key.
I say if it was the Warrens, there's loads and loads of really good feedback from there that you could capture.
Thank you.
Thank you. I think Robin's made a similar comment in the chat, so thank you for that. And I've actually seen them up at Berrywood on a couple of visits towards the impact of those have been phenomenal. Itai, I'm going to give you the last closing word on this. Thank you.
Yeah, I just wondered whether the charity has any appetite for partial projects. So, for instance, one of the things that we're trying to raise capital for is a T3 MRI scanner for the system, which will obviously enhance our ability to have faster scans for prostate cancer and also early onset dementia. With what we've done so far, we've managed to get some CRN funding, but we haven't got all the capital that we need, and we risk losing it if we don't provide additional capital within a certain period. But we understand that you might not be able to sort of provide the rest of the funding, but partial funding might go a long way in sort of convincing other partners to get on board. So I just wondered whether you've got a process around things like that.
Yeah, so I think so the charity's looked into that project anyway, and I think we need any project like that, we need to look at what the case for support is, and not the business case, but the case for support from a charity perspective and why people would contribute to it, because contributing to a piece of equipment is quite getting donations for that are quite hard. However, if we can tell a story beyond that, there's always an opportunity, and like I said, there's an opportunity for major donors, etc., to support such projects. But we really need a full sort of plan, business case to see where the charity can fit in, and also I know from experience of fundraising for multi-million-pound campaigns for medical equipment, it's not overnight. It will take a couple of year and a half, 2 years to raise the sort of numbers you're looking at. That doesn't mean we can't support. So I think from a charity point of view, we need more information. We need to understand what the funding shortfall is that you'd need a charity to contribute. Is that above and beyond the NHS? Where could we bring in major donors, etc., to support that, corporates, and then an element of public fundraising? But so it's definitely part of our strategy to support significant appeals, but we need to work more on that project.
Thank you, Jonathan. So on behalf of everybody, can I say thank you for a really insightful presentation? I think that's given us a really good background, but more importantly, looking forward and your new strategy, and I'm sure the commitment from the board for everything we can do to help support that. And I just wanted to add in a personal view that on all the different service visits I go on, the number of staff that say that there's an area or something that's been funded by the charity is incredible. So I think your impact, visibility is one thing, but the impact when staff talk about it, the impact for patients and for staff have been phenomenal over the last year. So a huge thank you. And I hope that's been really useful. I can see Krishni's come in for the very last word.
Thank you, Julia. Just a very quick practical point. Jonathan, thank you. Really appreciate you joining us today, and really great to hear about the work you're doing. I think the slides would be incredibly helpful to circulate if it's possible to have them. So that was just a practical request. So I'd be grateful if you wouldn't mind.
Okay, thank you.
Thanks, Jonathan, again, and we look forward to hearing from you at the next occasion. But I think you've opened up channels definitely for people to start being stimulated to think wider. So thank you very much for that. Okay, folks. So thank you.
Bye-bye.
Bye-bye. Thank you. So we're at 18 minutes past 11. We're going to head for a 10-minute break, if that's okay with everybody. So see people back at 28 minutes past. Thank you. Just waiting for people to rejoin. I think they've got another minute. Welcome back, everybody. I make it 28 minutes past, so we'll get going. Hope you feel suitably refreshed after that little break. So we're moving on to our integrated performance section of the agenda. And the first paper is paper I, the Alert, Advise and Assure report from the Performance Committee. And it's over to Judith again as chair of that committee. Thanks, Judith.
Thank you, Julia. I will take the report as read. I do want to, however, just draw out a few things in relation to the alert sections. So the committee discussed the financial performance, and that was at month 10. We were told that we're expected to meet the target delivery of the £4.83 million pounds deficit. And also since then, the industrial action costs have also now been met and covered by NHFT. I did, having been preparing for this part of the agenda, I did reflect that as soon as I wrote the AAA report, it had become outdated because the financial aspects of NHFT and NHS funding at the moment and finance generally is so fast moving. So things have moved on somewhat. We also discussed the 24-25 financial strategy and annual planning, which is an ongoing piece of work, which only last night has been given some sort of support with the release of the central document. However, we were at that stage assured that there was an ongoing draft plan and that the value programme, any additions to the value programme for 24-25 will undergo a clinically led quality impact assessment to ensure that we make balanced decisions. The really positive aspect of all the discussions around finance was that the financial aspects of NHFT was subject of a deep dive at the first Performance Committee workshop. So like QNS, I felt it was best for Performance Committee to have these opportunities for all members to have time to devote to really important matters, and it is proposed that on an ongoing basis there'll be an annual plan drawn up for subject matters to discuss during the year. The final item under alert heading is the mental health, learning disability and autism contract review. It was a good discussion around the next stage of the contract. The assurance was given that the level of due diligence that was going to be undertaken prior to taking on additional services was going to be high, and the final paper will be presented to board in due course. I don't propose to add anything to the assure items on the report, except to say that the integrated organisational report, which is next on the agenda, is continued to evolve, and Adrian Hand attended a performance committee, and the entire committee was congratulated her and her team in pulling together this really important and really insightful report, and we discussed the ongoing development as far as reporting up to board is concerned. And with that, I'll stop, and I'm very happy to answer any questions if anybody may have on that.
Thanks, Judith. Really good, clear summary. Thank you. Can I open the floor for anybody for any comments or questions from the Performance Committee? Anything specific? I certainly just welcome you're mentioning the quality impact assessments. We've raised that through several committees over the last few months and received regular, very strong assurance that that process continues alongside any changes that are planned. I just thought that was important to bring out because it guides all our decisions, really important aspect. Angela, thank you.
Yeah, just to remind colleagues really that as finance is clearly something we're working very hard with system partners on at the moment, and I know that's understood, but I think important that is continued work, and I know through Ned's involvements in subcommittees of the Integrated Care Board, that's also being understood, and I know welcomed that our Neds are attending those particular committees. So I think just to draw that out for people, because it is going to be important to not only deliver the position in 23-24, but that planning piece that you said, Judith, in terms of 24-25, we have to do it collectively, but also organisationally. Thank you.
Thanks, Angela. Really important points. Any other comments? No. Thank you very much. Thanks, Judith, for that. And then the last paper in this section is over to Dave Mayer for the Integrated Organisational Report. Thanks, Dave.
Thanks, Julia, and thanks, Judith. So again, quite comprehensive pack of material that I won't go through iteratively, but to draw out some themes. Waiting lists continue to be a challenge both for us and other organisations. We are making good headway with these at this point, despite ongoing pressures with more people going onto them. We had a pretty good detailed review session in the Performance Committee, which Judith referenced, which Anna's convened, and we had Janisa Baines with us, and I think we drew significant assurance about the work that we're doing, and particularly focusing on waiting well opportunities for people who are on waiting lists, and being really creative about how we approach supporting people when they're trying to access services. So that was a positive piece of work for Performance Committee to do. At the Health and Wellbeing Board yesterday, there was a conversation, the West Health and Wellbeing Board, there was a conversation about children's services, particularly SEND inspections, which have now concluded across North and West. The West report is embargoed, but fair to say it's comparable to the findings from the North, and there was recognition across the partnership of the need to do much more in that space around our children's services. I take some comfort in the planning guidance that popped in last night. There is some national funding now for children's mental health services, 70 million nationally, I think, in service development funding. Not sure what that looks like for Northamptonshire. We've got to work that through over the next few weeks, but that's positive and needed, I think, across services. So just to flag that. I'll draw in questions on turnover and workforce as we go through it, but we're rebalancing some of our workforce plans in line with the guidance required for the planning submissions this year. Hence, we've got some asymmetric kind of numbers in relation to turnover, but that should stabilise in due course. And of course, our primary issue relates to resourcing some of our prison services, our secured services. There has been a requirement that colleagues might be aware of that the NHS stops using off agency framework. These are more expensive agency staff when we can't use on framework, those that are part of our supply chain. We had to pause that, stop that by 1st of July, which for us is doable. We've got a plan, but it's an illustration of this complexity for secured services in relation to turnover and workforce. The other good news, we are now seeing real benefit from our length of stay work. Mitai has begun to kind of shape the delivery of that. Really positive in Barry to see length of stay coming down. That's really important for a number of reasons. It's important for staff and having a sense of pressure. It's important for populations and our communities in terms of having a sense of recovery. But it's also important for us as part of our value programme that we're able to use our resources wisely and well and have those benchmarked to be able to operate within an accepted benchmark. So that's really positive. Just to keep going, I'll come back to some other good news stories. We also had a conversation at the Health and Wellbeing Board about the Better Care Fund last night. This is the integrated pool of resource to help drive frailty pathways, reablement. Quite a lot of our integrated care teams are funded through Better Care Fund. And phenomenal results, I have to say. And I've been looking at Better Care Fund data since it was introduced in different roles, and I have to say, really positive as a measure of successful partnership and good integrated working. It is writ large in the data for the Better Care Fund. You know, people moved quickly out of hospital. It's still very pressured, as Anne said, and obviously a lot more to do, but the numbers tell a good story that we are heading in the right direction, and we're going to dovetail that with a refocus on integrated care across Northamptonshire, the old ICANN framework. We got commitment at the Health and Wellbeing Board to make that a solid programme that will sit across certainly the West, and we'll do the same in the North, and we'll be a key driver in that. And that's really important for our future plans and the shape of our demography as it ages over the coming 5 to 10 years. In relation to finance, as Angela said, you know, lots of discussions locally with that. We've got a framework now in place with partners for supporting a deficit position, which we as a trust supported and have been working through the implications of that. Our NOF, the segmentation was published by NHFT on the 18th of March. We had been in a holding position at a level 2 because of the way the finances were. We are being maintained at level 2, which is very positive considering the position most trusts find themselves in. So we feel confident for that going into 24-25 that we can begin to really knuckle down, and particularly on the performance dimensions in that we are doing very well. Linked to the NOF, there is a new framework in the planning guidance, so we'll make sure possibly as part of the board notes that we send out the guidance. It'd be helpful for people to see that, and that of course will then play into the performance committee routinely as an update. The team are working on cross-referencing where we are against that currently. And then finally, some brilliant innovation happening with the Rushden Memory Service. It's a one-stop shop. We're seeing greatly reduced waiting times now for people accessing that service, and that's also great news for our population, and we'll be replicating that across the county, really across those services. Brilliant agency reduction, as Krishni said, in our older adults, and seeing good reductions in crisis, community crisis reduction as well. Again, that plays into a whole quality piece for us next year as part of our planning, and is really, really critical to the experience of people's care, really. And then we've got some medical adverts out of positions, and we've had some interest from Scotland, I understand, for a post. So, well, either gives you an indication of how attractive Northamptonshire is to work in, or indeed how scarce and rare the clinicians that we need and want are. But that's good news nonetheless. So moving forward as ever. Thanks, Julia, and of course, happy to take questions.
Thanks, Dave. Really comprehensive update. Well, a very, very rich, detailed report that I know has been through both Performance Committee and Quality and Safety Committee. Just to add in a triangulation point from Quality and Safety Committee, that we have looked over the last few months in detail at 2 particular waiting lists, those for children with ADHD and those for adults, and we've been reporting through the assurance related to that. But it's from a quality point of view and a patient experience, harm reduction point of view. So it's really good to bring that together with the information from Performance Committee and through this report. So thank you for that. And some great, really good, positive pieces of news through all of that, despite some of the, again, challenges that everybody's facing. So could I open it up for any comments, questions? I'm sure everybody will acknowledge the development of the report. It's really maturing and gives us great richness for base for debate. So thank you. Paul, did you want to come in?
Yeah, thank you, Julia. Just to re-emphasise the points in the report really about, and as you'd expect, 3 days from the end of the financial year, I just wanted to be crystal clear about us hitting the £4.8 million deficit, which was the target that we agreed with NHS England back in December. So we will deliver that, and within that is sort of over £21 million worth of savings that the trust has generated. So my thanks to all that have contributed to that programme, but that's quite an achievement in and of itself, so I didn't want it to pass without acknowledgement. More to do for the 24-25 plan, of course. But nevertheless, it's always quite satisfying as an accountant to get to the end of March delivering what we said that we would.
Thank you, Paul. Really important note. Anything from anybody else? Angela.
Yeah, echo Paul's comments there, but I think importantly as a board, and I know again people know this, but important to say it, that that challenging financial context is one in which we are going to continue to need to look at the quality safety issues as a board. We may need to think about some difficult decisions in relation to that. As I've said already, we'll work with system partners, but it is important, I think, that we ensure we've got time and space to do that as we go forward. It's just putting it on everybody's radar, but hopefully everybody's aware that that's going to be necessary. Thank you.
Yeah, thank you, Angela. Really important point. Okay, thank you for that. Thank you for presenting that, David. That's great. So we're going to move on to our quality section on the agenda. And the first paper is from, I'm going to hand over to myself. I can just bear with me, get to my paper. It's a very long report, the integrated organisational report. Bear with. So again, as others have, I'll take the paper as read. This is paper K from our recent Quality and Safety Committee. I'll just draw your attention to a couple of items, 3 alerts at the top of the report, which we've identified the mitigating actions that we received in the committee, the Marina Ward closure update, and I had actually visited Berrywood at that point and was able to feed in some assurance from speaking to one of the members of staff who was actually on the closed ward at the time, and heard about the extensive support wrapped around the staff and the very individualised focus for patients to find them alternative accommodation. So just wanted to bring that in. And the delays in assigning investigators, we looked at that in detail last week at the Safety Committee again and took additional assurances. And the positive news that moving to our patient incident response framework, safety response framework, that will help with this. Similar incidents will be able to be investigated together collectively to determine learning and to be shared rather than focus on just particular individual incidents. And the assurance that we reiterated in that committee was that immediate safety concerns are investigated straight away after every patient safety incident, just to share that with the board. And then about secured services, they were mentioned in several pieces of assurance that came to the committee, and we felt it was a good time to think about how that information comes forward so that we can take a more holistic view of the quality and safety elements. And we are going to plan a workshop around that to get some ideas and look at best ways to improve our visibility and certainly our assurance levels for that, for our secured services. 2 quick things to mention in the Assure section. One was our workshop that we'd had in February. We'd previously brought the quality framework to the board, which was approved in January, but took the opportunity in the workshop to have a deeper look. And with the strategy refresh for the trust heading our way for 24-25, we thought it would be appropriate to review that in more detail, to refocus towards prevention and especially the emerging quality work across the organisation and the system around prevention, health inequalities and outcomes. So hopefully that will be an improvement. And just to draw your attention to the focus session, as I already mentioned, we looked at adult ADHD and autism services and took good assurance from the actions that we're taking, again, for a very challenging situation nationally and regionally. And just to highlight the Celebrating Outstanding, we've already talked about the first one, which was the flow direct stimulation that's been on the national news, and these innovations and the good practice from the highlighted from the Quality Forum, not to be underestimated. They're incredible. Each one is an incredible point and impacts many patients. So we like to celebrate that at the end. And then lastly from me, we're asking for an approval of some minor administrative changes to our terms of reference, mainly change of name and roles. So hopefully people will approve the terms of reference that are attached as appendix, the first appendix. Happy to take any questions or comments from anybody on the report. Anything anybody needs to raise? Quite happy with that. Thank you very much. So we'll move on to our Patient Safety and Learning Assurance Report, Paper L, which is Linda, our Chief Nurse. Over to you, Linda.
Thank you very much, Julia. This is a long report, so I will take it that colleagues have been able to read the report. I'll just tease out a few issues that I want to highlight to the board. So the first issue is on a review of our top 5 safety issues. Just to mention that we continue to have a really good culture of reporting. We've had no duty of candor breaches in the organization for this period that I'm reporting. And certainly we do see high levels of reporting, but when we've drilled down the information, you can see from the report that we are still reporting a high number of our incidents as low or no harm at all. We've spent time providing you with information on our pressure ulcers. This is an area that has been discussed widely in our patient safety group, with patient storyboards through there, and also a review of the process that we've now put in place to review pressure ulcers. So we have a working group that's reviewing pressure ulcers in a timely manner, which also the directorates have set up a process where they are actively reviewing. So with that work continuing, it then means any learning that's coming out of this is picked up immediately, and we should start to see a reduction in those that have occurred whilst patients are in our care. I wanted to also highlight on the work that's being done by the Falls Lead. So the Falls Lead has set up these sessions for teams. So she's done a lot of work, most, yes, through Teams, but MS Teams, but actually she does go out into areas to support staff on completing assessments, updating assessments, and just the back to basics around falls management, falls prevention. So that work is continuing, and with positive feedback from the different services that the Falls Lead has been supporting. Highlighted within this report is information on learning from deaths, which is absolutely key for me to note to the board. It's also really quite important that the period we are reporting here, we've not had any deaths that have been reported and considered potentially avoidable for our leader. These are our learning disabilities patients. So that's always a positive action that we take away from that. Julia has already mentioned with regards to the allocation of investigations. It's something that we continue to monitor. And just to mention that with our investigations, we do have some that have not yet been allocated, and that's due to the level of knowledge, skill that you require for the investigator. And where we've got our clinical investigations team, they too will be having other ongoing investigations. So we then look out to colleagues across the organization to then be allocated those investigations. So it is something that we're closely monitoring. Some of these have since been allocated with revised dates for submission, but we will take this back to Quality and Safety Committee with an update and a plan so that the most up-to-date information is shared there. We've provided information on our review of significant incidents. That's our ROSE forum, which replaced our internal assurance meeting, our IAMs. And again, we're now starting to see from the information, the number of incidents coming through and those that are being put through for an incident investigation. So it's starting to reflect what Julia's just mentioned, that we are not going to be doing reviews on all these, but we will have some that we will theme together, and the learning would still continue from each of these, but it's really specific around the incident that will have happened so that we're not duplicating the same information. So for example, where we've got a like situation for pressure ulcers, we would then be putting that together instead of doing 2 separate investigations. And there will be those that are more individualized, and that's part of the discussion within the ROSE Forum. We've provided information on thematic reviews that are taking place and where we are with the thematic reviews. And just to mention that a lot of information actions do come out of those, and that learning is shared wider across the organization and across our system where we've had our thematic reviews. The last bit I'll just draw board to is the ask for you to note the report, and this is at the end of the report, just so that we are providing you with information with regards to how we are managing our patient safety incidents, the deaths that we are learning from these, and also to update that we are monitoring our situation with regards to unallocated investigations, and it continues to be a priority for us. We also keep in touch with the families that are impacted, so we would not then have it unallocated and not be in contact with them to explain what is happening. So that is the ask with regards to this report. No decision is being asked, but asking you to note the information that is presented. I'm happy to take any comments or questions, Chair.
Thank you, Linda. Really comprehensive update. And I'll hand over to others and I'll come back with a summary at the end. Thank you. So you did, first of all. Thank you.
Thanks, Julia. Thanks, Linda, for a really superb report as ever. Just have a point of clarification in the report on page 2, where you, of the reports, is page 90 of the pack, where we have the treatment graph. For me to understand, the x-axis is the number of months, so it's March to February. Am I correct?
Let me just go to where you are, Judith. You've said it's page...
It's page 90 of the pack, or the second, the top of the second page.
Okay, I'm on page, I'm on page 90, yeah.
So the numbers on the bottom of that graph, are there no months in the year? So March, April, May, etc.
Yes.
Okay, and then the y-axis is the number of incidents, or number of reports rather.
Yes, it is.
Okay, so thank you for that clarification. In relation to the feeding under restraint, presumably, I'm just presuming here that sort of blip, that sudden rise, may be as a result of a few number of patients, and it might be, I think, a good framing of to presenting this data to actually say, well, we have 3 patients or 1 patient that requires this type of treatment, and therefore there is a direct impact on the data, because obviously statistics are only 2-dimensional. So giving that background would give it some frame and perhaps a less cause for concern. Just a suggestion. Thanks, Linda.
Yeah, thank you for that, Judith. Julia, would you like me to come in now or right at the end?
I've just wondered whether Anne was coming in on that point too.
Yeah, I was just going to support Linda with that one, if that's okay.
Thank you.
Just was going to say yes. This directly, I can see the pattern from specific number, very small number of patients. One in particular who's had been a very complex case, and the team have done incredibly well working. And we've had some real clinical developments that have been shared wider from that. But that's where you can see the spikes there, and that's usually the case with this kind of data. So that's quite typical, if that makes sense.
Thanks, Anne. Thank you, Judith, for that. Krishni, can I bring you in?
Thank you. It's a really comprehensive report. Thank you, Linda. I just wanted to pick up on a couple of things which are slightly unrelated. One was the patient safety syllabus and the discussion about whether that was going to be made mandatory. Obviously, very clearly, patient safety training is really important, and from what I've understood, this is obviously part of the new requirements. But I just wondered what thought we're going to give to what doesn't then go on mandatory training. I do worry, however, this is obviously really important, so I would completely support the need for that. I just worry if we're just adding more things into mandatory training, what the impact of that is, because it's always challenging, isn't it, for staff to sort of keep up to date on that. So that's just one point. And if I may just add the other so I can save time and not come back in. I don't know if I'm reading the data right, Linda, but I was just looking at the learning from death dashboard, and there is, I think, a suggestion that there is a probable, an avoidable death or probably avoidable death in Q3 of this year, if I've understood that correctly. And I wondered whether that feels quite rare to me to have that. So I just wondered what we were doing around that.
Thank you, Krishni. Do you want to come back in, Linda? Or do you want to think about that for a second, and I'll just bring Jo in for her question and comment and then come back to you at the end?
If you could bring Jo in and then
Yeah,
I'll
that'd be
respond
great.
to that.
Okay, thank you. Jo, do you want to come in?
Yes, thank you. So just following up on Judith's commentary around the graph with percentages and individuals, I think the same applies to the self-harm data, which is there may be one or two individuals that skew the data on there. So again, just a reflection on how we present that information. I was just going to raise a separate issue, which was linked to the medication incidents. And there's a comment at the end of the paragraph, which says that the electronic prescribing and medicines administration continues to be used and will be monitored. I think it's something from a board level assurance point of view that it would be good to see the connection between the impact of EPMA and some of the errors that are being reported in this table. I mean, particularly medication errors. So if we could perhaps just pick that up at some future point, that I think would give me a bit more confidence on that. Thanks, Julia.
Thank you. I wonder whether, Jo, that point, certainly we cover medicines at Quality and Safety Committee, and we had a quite an extensive and a review of the implementation of the electronic patient medication system. So if you're content, we may well pick that up, if Linda's happy with that, at the next Quality and Safety, and make sure that that's addressed with a pharmacist attends that there. That'd be great.
More than happy. Thank you.
Yeah, no problem. Thanks very much. Linda, did you want to come back in on a couple of Krishni's points about mandatory training and learning from deaths?
Yeah, I can come back in. So with regards to patient safety syllabus, what's been ongoing across the organization, and Anne and Chris can come in on that, there is a review of mandatory training. So where some of the training was done, say half a day, and then something else, we're putting the training together. So it's all days planned for staff, and it links in quite nicely together. Because we've got clinicians, learning and development colleagues reviewing training, it then means some of the information that would otherwise take a whole day, we're able to do that half a day and still get the training that's required. So we are reviewing the training so that where certain sections do not need to be duplicated, we can then avoid that duplication. One of the areas we find with a lot of the mandatory training, Krishni, is when you do it the first time around, that's where you've got most of your time in completing it. But as we go to the refreshers and updates, there's less time that's then involved. So we are mindful of that and ensuring that we're not adding more and more onto training that's duplicated in other areas. So we then put that together. With regards to the query you raised on learning from deaths, as you mentioned, yes, it's a potential. So when I'm reading this, it's still under review. So we'll confirm it at the next meeting so that that's clear, if that's helpful. Thanks for that point, Krishni. And
Thanks,
then,
Linda. Sorry.
Jo did raise the point around medications. We do go through that. Absolutely. We go through those areas, and happy to bring further information on that. We do go through that in the patient safety group, so we can link that information together and then bring it across through here.
Thanks, Linda. Jo, if you bear with me, I'm just going to bring Angela in, because
sure.
I'm well aware it's just gone 12 and she may well be leaving shortly, if that's okay. Angela?
Thanks, Julia. It was just in relation to the escalation of news, which is obviously identified as an issue that we need to keep very firmly focused on. And it was just to really highlight, Julia, in terms of the Quality and Safety Committee, we just need to make sure that that really is an area that's being focused on fully, and we understand what is happening, as well as taking action now, which I'm sure Linda can confirm is happening, but it's just obviously a safety element that I want to be assured about. Thank you.
Thanks, Angela. Absolutely, we'll take that back because we have in fact asked for a number of areas to go back to the Quality Forum to bring through to Quality and Safety back in April. Thank you for that. Can I bring Jo in and then I'll bring Linda in just to close?
Yeah,
we need
really
to
sorry, Julia, that I should have scrolled down. I've got one other point to raise on this report, which
Briefly.
was just a point on the demographic data. We have quite a lot of categories not being recorded. And I think it's important from the point of view of understanding differential impact on different patient groups to try and get as much data as we can. Particularly the one I highlighted was that 79.1% of patients are not recorded about their disability status. And I think it's important that we recognise that gap. Thank you.
Thanks, Jo. Really important point. Linda, I'll let you. Do you need to come back in very briefly? We've got 2 more of your reports following shortly. So anything else you needed to respond to for this?
Yeah, just to mention to Jo that the work around patient information being recorded, there's been ongoing work around that, and also ensuring that information is up to date. So that is something that's been looked into. So thank you for raising that. And just to mention that you are right, Julia, news and other areas are being brought back to quality and safety because those are going to be presented at the next Quality Forum.
Thank you. And Angela's assurance required was just that actions are being taken sort of today. And I think we'd received that in Quality and Safety, but needed some more detail going forward. Is that right?
That's right. We have the weekly monitoring around that, and it is reviewed in our early warning science triangulation meeting as well. And this week there has been various meetings with different ward matrons around that.
Thanks very much. Okay, thank you for that, Linda. We're moving on to your next couple of papers, really important papers around monitoring workforce safeguards. Paper M.
Thank you very much.
Thank you.
Thank you very much, Julia. So with regards to this report, just to tease out a few areas. So within the report, we've highlighted that there have been some areas where patient needs have been met, but there's been reduced staffing capacity. These needs have been met safely for patients, but has an overall impact on patient experience. There's 2 ward closures that we provided an update on. So Julia mentioned earlier about Marina Ward, which is reported within this report, and also around Orchard Ward, and Anne can give a further update on that. Just highlighting our mandatory training compliance for this period, which we're reporting at the end of February, and the work that's been put in place to get us to that position. I wanted to come back to Trust Board and highlight one of the risks, workforce risks, that we had previously highlighted and was also discussed within the Integrated Assurance Committee, and that's to do with our Section 136 suites having medical cover. So I can confirm, and Anne is here, Itai is here, that we have put medical cover in place. So there are junior doctors covering the 136 suite, as well as having consultant cover, which is now quite consistent. Other risks have been highlighted within this report. I wanted to also mention to the board around the work that has been done, particularly with regards to the rollout of the community nursing tool, which is the safer staffing tool for community nursing. So the training is ongoing. We've also reached out to colleagues to support us with the training. So we've got that support from NHS England. Our colleagues in LPT will also be supporting us. So we've put in place the proposals for how this will roll out across our community teams, and that information will come back once those reviews are completed. The reviews, establishment reviews for our inpatient mental health wards, those have commenced, and the reports and feedback will go through to our workforce safeguards assurance group, and this will then be reported to Integrated Assurance Committee ahead of it coming through to Trust Board. I'm happy to take any comments, questions, Chair.
Thanks, Linda. Again, a really important, comprehensive report. I'll just open the floor to colleagues for comments and questions. And while they're just thinking about that, I note in part of your exec summary around where we've had to close some beds in our CAMS units with the increasing trend for complexity of patients, or the increasing complexity of patients, and I just wondered if that feels perhaps possibly to yourself or to Anne, whether that's an unusual blip or whether that is a trend that's just sustained and is ever increasing. I don't know whether.
Yeah, so it's just to explain, when we've had patient with complexity, this will be a patient who requires more than 4 staff to safely meet the needs. So on a ward where you've got several other patients, unfortunately, you can't then have all those beds filled because of the complexity for one patient who needs to be managed quite safely within that environment. Certainly, I know that there's been a lot of work that the teams have done with one particular young person, and that's now starting to come across. And this was a patient that we'd had in our care for quite some time. So again, where you've got that young person, unfortunately, we will have higher levels of restraint to do with that individual. So you can't then have other beds open because you are requiring that level of staff for that particular patient. I'll let Anne come in because she will add on to that, and then she can just provide the update for Orchard Ward as well, if that's all right, Chair.
Thank you. Thanks, Anne. Just briefly, if you would, that'd be great.
Yeah, yes. I mean, just Linda's spot on, really. We have to work the wards with the young people around what their needs are at the time. And we have had some really complex cases since I've been in post, where we really had to work through how to safely manage in the environments that we've got, and also thinking about, if someone's staying on a ward for quite some time, how that care environment works together as a group, because part of the impact on young people is the people that are around them and their peers, and so we have to be really conscious of that and careful in the planning of that. So we have had cases where we've had to reduce because the staffing levels are required to give some quite intensive interventions, and that's been very planned through. It's been done through a clinical forum, and it's also done in conjunction with the collaborative. So it's very it's not a quick decision. It's a very planned and processed decision to get the best outcomes. And last, well, this month just gone, we've seen celebrating a discharge of one of those very young people who came in very unwell and distressed, and we've gone through that process with her, and she left, as they described her, a really fantastic young woman to go and develop it in her life moving forward. So I think we know that it works. It's just we have to manage each case as they come through. So.
Thank you, Anne, for the update.
Do you want me to talk Orchard, Linda and Julia?
Just very briefly, if you would. Thank you.
Yeah, so we did some work within the value programme and within the teams before Christmas. I'll get my dates muddled up. And we've had consistently over time vacancy within our older adult beds. So we've had empty beds, and obviously we have to staff those beds as if they were full in case people do come in. So as we've had this consistent pattern over years, and we have had to at times staff those with non-permanent staff or not the usual staff team. So that's obviously an increase in some of our agency usage. We've done some work just to reorganise some of that bedded environment, and for permanent staff to all come together in one area and work together to get really good outcomes for our patients. And the collaborative are doing a review at the moment with partners, with stakeholders around what really should that provision for older persons look like going forward, because if people aren't in beds, people are in the community, and actually how do we best fit the services that we provide. So that's where we are at the moment. We've had some really good strong support from the Carers Association wanting to come in and support in that review, and other organisations, so that we can make some decisions. Now it might be that it might be a bedded option, it might be something that looks a little bit different, but it's an opportunity to see what's best for this population. So that's where we're at the moment.
Thanks, Anne, for both those updates and additional assurance around our closures for our beds, etc. And thank you, Linda, very comprehensive report, and thanks everybody for their comments, etc. So could I move us on to the Complaints Pals Concerns Compliments Q3, Linda, please?
Thank you, Julia. Another comprehensive report. So I will take the report as read, and I'll just highlight a few areas for the board. So one of the areas I wanted to highlight is on our overdue actions from complaints. So this is an area that myself and Anne Huzaku have discussed, and I can confirm that these outstanding overdue actions are now discussed as part of the management meetings that the divisions have. So we will start to see those reducing, but we'll continue to monitor that. The next item I wanted to just highlight is with regards to the learning. We've provided some information on the learning, and we do discuss this and have cases that we then review as a complaints group. So wanted you to be cited on that. I also wanted to provide an update with regards to the carer strategy review. So just to mention that the carer strategy review, that piece of work has been completed. It was co-produced with carers, peer support carers, various stakeholders across the system, including the charity St. Andrews, and the draft of that was presented to Quality Forum. Comments were made, so it was revised, and the next iteration will then be going through to Quality and Safety Committee for review comments ahead of that being presented at the next trust board, which will be in June. So that piece of work is ongoing. I also wanted to just provide some assurance with regards to our reporting on our new feedback system, Equivia. We are starting to see the increase in feedback. And whilst we are seeing the increase in feedback, I just wanted to highlight that work is still ongoing to make feedback more accessible. So we've got some teams now that are trialing the text messaging and various other formats so that we can receive timely feedback, as well as the different leads having access to that feedback so that they can respond to it in a timely manner. I'm happy to take any comments or questions, Chair.
Thanks, Linda. Really clear, informative report. And just to add in that we recently discussed with Council of Governor colleagues around patient feedback and the IQVIA system and how the complaints committee feeds in and the assurance we take from that. So that was helping them to understand the assurance we gain through these different committees. So just to feed that in, thank you. Krishni and then Melanie, thank you.
Brief comment. Thank you very much, Linda, for another great report. And actually, I was going to mention, Julia, that you and Robin very kindly led an item on this with our Council of Governors. But actually, interestingly, I wanted to just pick up that I happened to meet with our Admiral nurses who are part of our Aging Well service. And we were talking about feedback, and it was really positive because they were saying they were looking at how they were going to adapt the IQVIA system to enable them to get feedback, because the support they provide is to carers and family members as opposed to the service user themselves predominantly. It was important to be able to adapt it, and they were having a meeting to look at how they were going to take that forward. So I found that quite assuring that the system seemed flexible enough for us at least to be looking at that, which was encouraging. Thank you.
Thanks, Krishni. And Melanie.
Right, thank you, Julia. Yeah, I was reflecting as I read this report on a couple of considerations, maybe, Linda, to think about, how to develop the report even further. I wasn't sure that involvement and carers strategy review sat well in a report about patient feedback, PALs, complaints, etc. It seemed a bit of an anomaly in the report to have that content in the midst of all of this. So maybe just a consideration as to whether this is the right place to include that update, and if the board needs to see it, is there a better cited location maybe for that particular content? I also was just reflecting on whether there is any kind of mandatory need to have PALS complaints and Equivia increasingly sort of separated out, because as I was reading through the report, I was thinking that sort of reporting in its channel of how we received the feedback actually gave us loads of data all presented independently, and made it actually very difficult to bring it all together and to get an overall perspective. Because to be honest, I don't really care whether we've received, I mean, I think I care about formal complaints, but I'm not really too bothered about whether we've received the feedback through PALS, through Equivia, through whatever channel it's reached us. The feedback is what we're really interested in. And I wonder whether it might be timely, as we get more and more Equivia feedback, to just think about whether there is the opportunity to start to blend all of the data into one set of patient and service user feedback, rather than continue to dissect it into its different channel. So something to consider, Linda, maybe, as to, and also to make this report a little bit more digestible, maybe at board level, a little bit more succinct and a little bit more kind of what are the key learnings that we're taking from our patient and service user and carer feedback and other categories of people who interact with our service. So I'm happy to pick up a discussion with you offline, Linda, and expand on that if it helps.
Thanks, Melanie. I think that's a really timely reflection, really, because it's maturing and our systems are maturing, and actually how we see this in holistically, the experience of people who use our services is really important. So I think perhaps, Linda, if you'd be happy, just in the interest of time, whether we could ask you to take that away and have a think, either conversation with Melanie, conversation with colleagues, etc., to see what might help improve and other places could consider.
Yes, happy to connect with Melanie to discuss further. Thank you for
Great. And Krishni suggested perhaps the complaints committee also could consider that. That would be very, very useful. So thank you, Linda, for that section. That concludes our quality section. Just in the interests of time, we're moving on to another really important section, our people. And I think Chris is leading the next 3 papers. Very important areas, Chris, but just so you're aware of timings, that would be great. Thanks.
Yeah, do you want me to, I was on the staff survey going to draw the highlights out though.
Yeah.
Is that okay?
Oh, yes, definitely. Thank you. Thank you, Chris.
So obviously surveys October, November, published in March. Just to highlight, very positive on the people promise. We've had, we're above average on all of those and 5 significant improvements. So I think it's really worth noting that's a really good result. Also, the response rates increased really significantly, the highest we've ever had, increase of 13% to 60%. Again, a key measure is the staff engagement, is recommendation place to work and receive care. And for the first time, we've had both of those increase. We've also had significant improvement of our compassionate leadership, and I think that probably really represents the work that we've done with the compassion commitment. And indeed, we held the conference yesterday and formally launched the compassion commitment. So really good response from everybody about that. Health and wellbeing, positive responses about managers and wellbeing, which has been something we've traditionally had real challenges with. But there is, I think the whole theme of the report is very positive, but there are some hotspots. And I think a hotspot there is that there's been a drop in the view of the organisation on health and wellbeing. Whilst managers have gone up, which has been traditionally challenging, the organisation has dropped somewhat. That's been an in-depth discussion with the wellbeing group, and we'll be taking that forward. On the res, I think really encouraging 82% increase in the response, which I think probably underpins that people see us taking this very seriously and they have the confidence to come forward. I think one of the real hotspots, and I think it is a real concern, something that we know we've got to really do more on this, is that 3 of the main indicators have deteriorated. And given the work we've done, I think we would have hoped they'd improve, but they haven't. Measured against that, however, and huge amount of co-production with the REACH network, we've got really ambitious plans to continue to address some of these issues. So we've got the career development programs for our ethnic cultural minorities, and the inclusive recruitment programs are also progressing, which will build on our cultural ambassadors. Again, a big increase in the response rate from our disabled and colleagues with long-term conditions. A lot of those indicators have increased, but the harassment from colleagues and patients equally also concerning. So that's an issue that we do need to focus on. The feedback on the reasonable adjustments is really positive, and I think that reflects the health passports and the work we've done with managers to address that. And staff survey also concerning, as the colleagues will know, we've raised that through the IAC and a number of areas. We've focused on sharing that and shared it directly with the board, all the good work that's going on to address those issues. We've also got the bank survey, so 2% increase in the recommendation as a place to work, some improvements on embedding compassion, but we know from the information we've shared on this before, there's still a lot of work to do. So moving forward, we will be sharing all the information, focusing on improvements, continuing to embed our compassion commitment is key. All our work on the WRES and WDES needs to move forward together against racism, and things like Operation Cavell, the whole issue on staff safety. So I think overall, I'd ask the board to take assurance that we have really positive results. I think we've had a really good staff survey, but there are a number of areas where there are real issues that we want to address. We've got plans to do that, but particularly say on the RES, the WDES, the wellbeing, we need to continue with the work and not underestimate that we still want to improve things and move forward.
Thank you.
Happy to take any questions.
Thank you, Chris. I'm going to open the floor to Melanie. Thank you.
Yeah, well, not exactly a question. I just wanted to really commend every single team across the trust for managing to achieve such a significantly increased response rate, and particularly in our protected characteristics, because that's a real sign of the commitment the trust is putting into using the staff survey as a means, one of our many means of gaining staff feedback. And I also wanted to commend you, Chris, on the paper, which I think was a good detailed reflection on the areas where we have success, the areas where we still have challenge. And I took great assurance from, in reading the paper, not being surprised by or sort of seeing anything that wasn't already covered by work that I know is ongoing from the Wellbeing Steering Group and from the other areas. The only I think element that I think might be useful for the Integrated Assurance Committee to maybe just reflect on is, are there any, when we look at these results at that very high level, we know there may be some areas or particular teams where the results weren't quite so good. And I just think it might be interesting for the Integrated Assurance Committee to maybe just get some assurance on where we have hotspots in teams, or maybe particular pathways that may need a little bit more focus, and something that is maybe a little bit more customised for the needs of individual teams or pathways. So I think that might be an interesting, different perspective for the Integrated Assurance Committee to take to gain further assurance and also potentially to add more value. Thank you.
Yeah, just to give some assurance to the board quickly in response to that. Gavin Morris, our new staff engagement leader, has been meeting with a lot of the staff. I think she's seen in excess of 100 people now to share the results and talk about coaching people about how they use them. And she's going to be working as part of our Let's Talk work with the teams, and we can feed that back. So absolutely, Melanie, that's something we're looking at, but it is really important that we make sure we take that forward.
Thanks, Chris. I'm going to bring the others in. I wonder if they make their comments and questions, and then we wrap up collectively, Chris, with that. That would be great. If that's okay. You did.
Thanks, Julia. Really briefly, echo everything that Melanie has just said about the real positives in the report, so I won't belabor that. The area that I just wanted to understand a little bit more as to what we're doing is in relation to the two questions where we had a slightly worsening of results, which is the staff raising concerns about unsafe clinical practices and perception of the organisation. to learn from these incidents, learn from incidents. I mean, clearly from a clinical and from a quality point of view, those two deteriorate or worsening stats is concerning. So just wanted to understand what it is that we're doing to try to understand why that happened. Thank you.
Thanks, Judith. Chris, should I take another couple and then see if you want to come
Yeah,
to...
I think, yeah, and I think other colleagues will want to come in because Linda would probably be best to answer that. But yeah, let's take a few.
Okay, thank you. Tim.
Yeah, I'm not going to repeat the comments from others. I just would add to the congratulations to all those in leadership roles across the trust who've helped gain confidence of staff, because I know this is a team effort. And I was just going to pull out, if we've got more people responding and responding in this way and feel more free to speak out, does that mean that where we're looking at things like staff safety and results have gone against us, that actually that's really important in these areas, because they said we did is a really important action out of all these surveys. But echo everything everyone else has said.
Thanks, Tim. I'll bring Linda in shortly to look at both of those. Scott.
Yeah, thank you, Julia. I mean, I think some of the points are getting a little repetitive. I won't echo all the positives again, right? But obviously, I do feel that. I was going to almost word for word raise the point that Tim's just raised about, you know, are we seeing more people having confidence to report aspects of the physical violence? You know, it might be a factor for us. The only other thing I would say is, and again, it's very close to the point that Judith just raised a moment ago, staff raising concerns about or feeling confidence and raising concerns about unsafe clinical practice. I think that's really going to come under the microscope, because the departing officer for that for NHSE was all over the press this morning, saying that, you know, he feels that that's kind of at an all-time low for the NHS. And, you know, after 7 years being in the role, he was saying that that's a huge area of concern. So I think from our perspective, we will need to be seen to be all over that. I don't need assurance now. I don't need a response directly from Chris. But as a trust, I think it's one that we're going to have to redouble our efforts and focus on, I think.
Thanks, Scott. Really important. And it's, as you say, it's building a theme from these points that are going through that we'll come back to in a second. Sakib, do you want to come in?
Yeah, really good report. Great to see the improvements. The bit that I just wanted to ask Chris about was on the real recognised and rewarded. That obviously improved, but wanted to know whether we are aware of. I think I read something yesterday that there are going to be some payments to some members of staff by the NHS yesterday, like a one-off payment. So whether we have any awareness of that, and then also whether a salary sacrifice for groceries has been considered. Keeps coming up on my LinkedIn feed and I've never seen it anywhere. So I was just wondering whether that's something, especially in the light of the subsequent paper on the pay gap as well. Thank you.
Okay, thank you. I wonder if we could just take another couple and then we'll address that for you, Sakib. Jo.
Thanks ever so much. Without wanting to undermine all of the really positive things in the paper, I support Melanie's proposal to get a bit under the skin of some of this. The table that causes me personally most concern is Appendix C, where we have some really clear issues, particularly around bullying and harassment, and the difference between different groups in our workforce. And I think we need to have a closer look at some of that stuff.
Okay, thanks, Jo. Krishni, can I just bring you back in?
Thank you, Julia. Chris, I mean, in the interest of time, I do wonder whether some of these things we just need to think about taking them outside of the meeting. So again, I think it's one of those things that probably not for now, responding now, but given that there was a new sexual safety question and asked in the survey, and I think there's quite a lot of concern about sexual safety as a sort of an area of focus. It was certainly mentioned at a regional chairs meeting on Monday, and we were asked to particularly look around, you know, having signed up to the charter, what does the data tell us? Where are we with this? So I just wanted some assurance around that and how we were taking that forward. Thank you.
Quickly come back to that, Krishna. Yeah, our organisation is very much sitting below the average on the experience of it, and then How many times people have been targeted? So we are very much around the average on that, or just below. We have got a lot of work going on in this area, which Linda's leading and Liz O'Leary is involved in, and we've got a sexual safety charter that was there for patients, but it's now there for staff as well. So I think we can assure you that, yes, we're conscious of that. We've not spiking in comparison to others, but we have got work being undertaken and taking that forward, and obviously feedback. But Linda might want to come in on that.
Linda, did you want to come in briefly?
Yeah, I'll come in. I'll add on to Chris's point and then just come in on one other point. So for the Sexual Safety Charter, we signed up to the National Sexual Safety Charter from NHS England last year. We've got an exec lead, that's myself, and an operational lead, and that's Tabby, who's head of our safeguarding. We then completed a gap analysis to check. So the charter states out the things that we're supposed to have in place. We did that. And some of the areas that we've now worked to are having a policy. So we did have sexual safety reference for staff in different areas. We already had a policy for patients. So that policy now has gone around to various stakeholder groups and will be coming through to Quality Forum yet again after comments ahead of going to policy board. We've also done some work which is currently ongoing around things like posters, and we've got the plan. So we presented last year to Quality and Safety Committee, and we're due to present again quite soon to Quality and Safety. I'm not sure if it's the next one. Most likely it will be the next one, but it's still captured within our report that comes through from safeguarding, because that's where all the work is being done and being discussed. So this is an area of focus for us, not just with regards to incidents, but actually the preventative side of it. I just wanted to come back with regards to the issue of staff raising concerns and feeling that we are not learning. So staff are raising concerns. We see that through Freedom to Speak Up and various other colleagues who then share those concerns openly when we go out on service visits and in other areas. What we've not been good at is where it's going to take longer to resolve the issues. So for example, where staff have said it's really unsafe with regards to our staffing, yet someone else has resigned. We know in the background we're doing all this work for recruitment, but actually there's nothing that's been communicated in between. And if you're that member of staff, then you feel that actually we're not listening, we're not learning from what has happened previously. We also know that we can improve in how we engage staff more where there are issues, not to take it away and try to resolve it ourselves, but actually to involve them in those discussions. So it's an area that we are looking at and focusing on quite closely, and we will be able to bring that back and report.
Thanks, Linda. Really important. I'm just going to bring David in. We're going to close this very shortly, but I'll just bring David in.
Thanks, Julia. I mean, agree. I think more discussion kind of maybe in a development session, but just to flag one of the metrics that I think is reassuring. We feature in the top 5 or 6 in the country for people speaking up and being inclusive. And that really chimes with the Freedom to Speak Up data, where we're seeing kind of a majority of people now speaking up openly. For me, that's such a critical metric, because as Linda says, that's an illustration of people feeling confident that that they're safe to do so, and B, that somebody will listen and try and do something about it. And I just think that's kind of one to keep in the back of our minds as an important measure. Those two things linking together opens freedom to speak up, and then people rating themselves, high in terms of being included and able to raise concerns.
Thanks, Dave. Just to say, we've obviously stimulated rightly a huge amount of interest, questions, queries, and focus on this, which is really important. And I know there's some piece of information that we'll take forward. Just thinking about the next item is going to be the people plan, which I think we'll probably just note, Chris, as the update is coming on the people plan looking forward, is actually coming to the May board, and perhaps we'll take the opportunity there to address some of those questions raised in the survey, and also at the integrated assurance committee, which focuses on people. There may be some elements we could pick up there too. Well aware, Sakeev, we haven't focused on rewards, etc. But I think in the interest of time, some of this detail we could take out of here and then make sure it feeds back in so the board are assured. And Itai, I did note your comment in the chat around safety. I feel we've had some assurance around patient safety incidents. If you're content, unless there was anything particular you needed to add around the safety incidents, if there isn't, I'll close that if you're content for that. Okay, thanks very much. So Chris, back to you for the last couple of bits. People plan paper B, if you're happy that we note that. Is there anything you needed to say around that? If not, we'll move on to the annual pay gap and then our last section.
So if people are content to note it, yeah, I would have drawn out highlights, but I think they're probably self-explanatory within it.
Great, thank you. Just is there anything anybody needed to comment on the people plan? I'll say the update will come to the plan for the year will come to the May board.
The future plan will come, yeah.
Future plan, sorry. Yeah, sorry, future. Great, we'll move on to paper Q, which is the annual gender pay gap reporting.
Yeah, so this is a record we're required to publish. It works on assessing the average hourly rate. I think we've made positive progress on that. We've reduced to 15% from 17%, so that shows a steady improvement over a period of time. And then the median pay gap equally has also improved from 7% to 3%. And it compares well nationally to the 14% that is across the board. So I think benchmarking and then benchmarking with other trusts, we compare favourably in terms of the work we're doing. And the issue on the bonuses, just so people understand that, obviously the bonuses on the average, but the median where there is that big gap is that we've got lots of bonuses being paid. The majority of our staff are female, so a lot of the bonuses, lower bonuses, are paid to lower in the staff, and then the higher bonuses relate to much smaller groups. So when you take the median, that's what gives you that outcome. We've also underpinned all the work that we're continuing to do to take this forward in terms of flexible working support, which often supports female colleagues with responsibilities, and we're promoting that very heavily. We get quite a good positive response on We Work Flexibly. The CEAs, which factor into this because we've got more males in the consultant group, so we need to manage that as the new CEAs come in. We support International Women's Day, and our career development workshops are a real focus. A key part of this, I think, the improvements is we focus more and more on recruitment and improving the fairness of our recruitment and a support to people, so that, as I said before, the inclusive recruitment and the recruitment ambassadors, all of those really do support that. And indeed in inclusive recruitment we do address a number of gender issues that factor through in recruitment. So we are steadily improving. We need to keep the focus, need to keep the initiatives we've got that are creating those improvements so that we can continue to move to our goal.
Thanks, Chris. Really, really good, clear report outlining some really good work that's been going on, and thanks to everybody involved in all those initiatives that we've been undertaking and plan to do. Any comments from anybody? We are asked to review the information, approve the data submission to the government website and publication on our external website. Scott and then Joe. Thanks.
Yeah, thanks, Julia. I know we're up against it for time. I'll keep it brief, right? Chris, you know, lots of really positive, noteworthy progress contained within the report. And I get also that the format of the report's quite tightly constrained because it has to be reported in a particular fashion. This is the sort of question you can chuck in as a soon-to-be outgoing non-exec director, right? But you know, have we made such noteworthy progress?
Thank you for that, Scott.
That's me just telling you the pins coming out of the grenade, right? So, given that we've made such progress over the course of the past few years, right? It still seems to me to be an anathema to have any format of pay gap at all. I find it, you know, I struggle with it as an individual, and I struggle with it, you know, that it should be in any way acceptable. And I'm wondering whether, as an organisation, we are now in a time frame where we could see an event horizon where we were prepared to give a commitment date that said that we would close the gap entirely.
I don't know that we can. I don't think there's a clear action we can take that would lead us to that. I think we are continuing to improve. I do think a lot of it is around supporting people with career development, because obviously it is about the fact that we have more males in some of the higher grades. So I think that career development is a really important part of it, and we're doing work on that. I suppose what we can do, and I think we are doing that, is we will increase the commitment to that. I also think there is a big issue here with recruitment and how we improve recruitment, and we haven't really had a chance to feed that back yet, but we've done inclusive recruitment, which is a process that really does challenge the people how they do recruitment, and it's raising issues about the processes, how we really improve that. And I think having really good recruitment processes is the two sides of it: support the career development and have good recruitment processes. So I think it's hard to see what a clear date and answer is, but I think we can commit to doing more work on the things we know are making a difference.
So I kind of anticipated that would be part of your response, Chris, and I think it's entirely fair what you've just said. The comment I would make back to you is, if we were able to make that statement, if we had that aspirational commitment as an organisation, what would that do for our recruitment? What would that do to attract people, you know, into more senior roles as we go forward, because they believed that, you know, we're committed to it as an organisation? I'm posing it as if it sounds like a question, Chris. It's almost rhetorical, right? But the point I'm making here is, I think, you know, this progress feels like really material progress, and what have we have to, again, over the course of the next 3-year period, have we missed an opportunity to be really ambitious? Is the challenge I'm making.
Yeah, I think if we can take that away, but I think it is emerging in other areas that sometimes we're not communicating what we're doing as well as we could, and I think this plays very strongly to, if we take gender as one of the protected characteristics, it plays hugely through to the race issue as well, about our commitment to say we will be truly fair. We really, you know, we do say that, but could we do more to publicise how strong our commitment is? I think it's a fair comment, Scott, that I'm happy to take away.
Thank you. Thank you. Really, really important comment, Scott. I'm really glad you made that. That's really important. Joe, very briefly.
Yes, sure. I mean, Scott's taken the pin out and offered some of the suggestions I was going to make. I genuinely think that there are others doing this better than we are. And I think as a learning organisation we should be open to how we can improve this situation, because it really isn't acceptable in this day and age. And I accept that there is steady progress, but I don't think steady progress is good enough for a trust of our calibre. So that would be my challenge.
I suppose if you've got insight to who those people are, Joe, that would be very helpful.
Certainly, Chris, and just looking at our recruitment material, we really don't make much of this, so I think there's lots to do.
Yep, that's helpful. Thank you.
Thank you. Really good, helpful comments and suggestions. So I'll close that there. Thank you very much. Joe, you've put your hand up again. No, great. Thank you very much. Okay, we'll move on just to our last brief section, governance and assurance. And Saqib, we're moving on to paper R, which is the Alert, Advise and Assure report from the Audit Committee, please.
Yes, I'm the sandwich between this and sandwiches and the standing orders. I will take the paper as read. The only things I wanted to highlight was the involved repayments that we've mentioned. Linda gave assurance that those are being worked on, and so that's in progress. There are a number of cases, high profile, high value, that are coming to an end under the investigation under fraud. So I think one was a member of staff working for another trust at the same time, and the other was the amount of claims that they'd put in and the value of them. In terms of development session, we're proposing that, just like has been done in other committees. So we're proposing that's done for audits as well. And then also working more closely with the other audit chairs across the system for collaborative working. So I'll close it there. Thank you.
Thank you very much, Saqib. Any comments or questions for Saqib for the Audit Committee? No, thank you very much, Saqib. Paul, to you for paper S, the Standing Financial Instructions and Scheme of Delegations, briefly, please.
Yeah, thanks, Julia. And to be fair, Richard Smith has done all of the legwork on this. What we wanted to do was to bring the SFIs and the scheme of delegation up to speed. We have done so. We think it fits with the latest best practice. And the other thing as well it does is takes into account, or as best as we can at the moment, takes into account the new duties of things like NHFT as a lead provider or in the collaborative space as well. So that's tried to reflect it here. Richard, I don't know whether there's anything further that you wanted to sort of highlight from the report before we ask for approval.
Only to thank Peter Howie, who's facilitated this work for us. Many people will know Peter from his former role at Lincolnshire. I think he's done a sterling job, so thanks to Peter, but otherwise, Paul, no comments. Thank you.
Thank you. And Julia, we did take this through Audit Committee in December, I think it was, and Strategic Exec Board more recently earlier this month. So it's already been considered.
Thanks, Paul. Important information under its journey. Quick comments and suggestions. Judith.
Thanks, Julia, and Paul and Richard. Just a quick question, a couple of quick questions actually around the section around charitable funds. Do we not need to specify a number of trustees for the NHFT is putting forward? That's number one. And number two, are we aware that the limits that we give ourselves for approving applications for funds internally is lower than that for KGH and NGH, and I was just wondering why that was. Thank you.
Thanks, Judith. Shall I just take Saqib's comment and then come back to you, Paul, to close? Thank you. Saqib.
Yeah, it's a really minor point, but I think on page 232 and probably elsewhere during the document, it says, I think Finance Director rather than Director of Finance, whereas elsewhere it, for example, says Deputy Director of Finance. So just for consistency, that needs tidying up.
Thanks, Saqib. Paul, do you want to just come back quickly on the...
Yeah, on both points, if I can, Julia. On Saqib's point, there are differences between Finance Director and the operational Director of Finance, so we just need to make sure that we get that crystal clear. So thank you for that. And just in terms of the limits, certainly we can specify the number of reps that we put forward to the charity board, and we will check on the limits. There may be reasons for it, Judith. I can't think what they would be off the top of my head, but a degree of consistency seems pragmatic. So again, we'll reflect those in the final version.
Thanks, Paul. So colleagues, are you happy to approve this just with those, ask Paul to make those two checks? But otherwise we've approved. Extensive piece of work. Thank you very much to everybody involved. Everybody's nodding, so that's great. Thank you, Paul, for bringing those. So moving on to paper T, improving our constitution with Richard. Thank you.
Thanks, Julia. Yes, the length of this paper sort of disguises the extent of the change that's proposed here. It really is only proposing a change to clause 8.2 of Annex 6, which actually stems from some learning that the Governors Standards Group has made concerning appointed governors, which we would know colloquially as partner governors. I won't go through all of the details. You can see the proposed amendment there at the bottom of page 1, and you can see it in context in the appended constitution. It's worth noting the Council of Governors has already approved this change earlier this month, so subject to the board's approval, this will then become live following today's meeting. Thanks very much.
Thank you, Richard. Judith, you have a question.
Yeah, Richard, I'm afraid I do. There is actually a typo in the proposal. There is a reference to their behalf rather than the behalf. And secondly, I'm not sure I understand this concept of a deputy. Is this another governor who deputizes, or is it a family member or a colleague? I mean, we've got eligibility rules, so I'm sorry, I was unclear, so I thought I'd raise a question. Richard.
No problem. Thanks very much, Judith. I think there is correct actually, because it refers to the organisation, but I'll check that. In relation to the proposal, yes, so it would be another representative from the organisation. So if we take, for example, the North Northamptonshire Council, for instance, they would nominate a member of that organisation to be the appointed governor. This proposal is to enable them to nominate a person to deputise should that appointed governor be unable to attend meetings. So it's really very limited to the contribution of that individual to meetings. And currently the ability to nominate a deputy rests with the individual governor that's been appointed. This proposal is simply to say, actually, we think that decision should rest with the organisation rather than with the individual. So yes, it is a member of the organisation, not, as you say, somebody associated with the individual person. Hopefully that makes sense.
Thank you.
Thanks, Richard. I'll just bring Krishni in.
Yeah, so I was just going to add to what Richard said. It's a really minor change to an existing provision. We already have a provision for deputy partner governors. It's just at the moment we ask the individual, and we simply want to change it so we can ask the organisation to provide for a deputy. And bearing in mind that it's the only governor role that for whom we receive nominations as opposed to going through elections. So it's a relatively straightforward administrative change, I think. Thank you.
Thanks, Krishni. Are we all content to approve? Yeah. Okay, thank you very much. Thank you, Richard. Thank you for that. Last formal paper, oh no, one more paper, the joint highlight, the AAA report from our joint working group with our work with Leicestershire Partnership Trust, which I jointly co-chair with the deputy from Leicestershire Partnership Trust. And we brought you an update. The meeting was only literally a week before the last board, and this is the formal report. I don't know if David, Williams, has anything particularly to draw out from this?
Thank you, Julia. All I was going to say is there's nothing to alert or advise the board. There was good assurance and ways of working through. I'm conscious that I won't do the conversation justice today, but really good conversation around Together Against Racism, the work of the collaboratives, all of our joint working group priorities and our strategy, and really having a look and showing and revealing the added value that this work, the joint working does. I appreciate that there wasn't a huge amount of time to go through that today, but it's a really important part of bringing everything together and collating things. And it's also helping us shape the strategy, which we'll be discussing as a board in future meetings and ways forward. So I hope that helps.
Thanks, David. And we will absolutely be focusing on the Together Against Racism, excuse me, programme in much more detail, I think, going forward in future months. Judith, and then Robin. Thank you.
Yeah, thanks, Julie. Just really briefly, having read the minutes, one of the things in the minutes, it says that that there needs to be some work to ensure that everybody within the trust actually understands what the joint working group does. So in that vein, would it be possible to share the terms of reference for the working group? And just to hark back to what Joe was mentioning earlier on in regards to the PCREF webinar that we attended, I mean, clearly this group is responsible for that piece of work under Together Against Racism. So it'd be really good to have a deeper understanding of what is happening in relation to that, so that, because we do, as non-executive directors, have responsibility for it. So yeah, that'd be great. Thanks very much.
Thank you, Judith. And Robin?
Judith's just said exactly what I was going to
Okay.
say as a result of the PCREF thing.
Great, okay,
Lovely,
thank you.
Terms of reference we can happily share, but they've been to this board before, because joint working group reports to this board, we've signed them off, but more than happy to share. And any of the racism work is probably good board development conversations and topics that we can feed in.
Exactly that. Thank you very much. And we did note last time the joint staff launch that several of us attended, and that went down very well. And I think Focus for Development session sounds a really good idea. So thanks very much for that. Okay, thank you, David. Moving on to the item for information, which is the board's declaration of interest, paper V. Just if there was anything, it's an item of information only, unless there's anything else to add to that. No other business from me. I'll just come back to Scott at the end in just 1 second. So snapshot of our performance with the questions that we duly look at the end of each board meeting around appropriate items and timings and anything else we need to amend from the risk register, etc. And our due regard to equality. Any comments from folk? Melanie, thank you.
Well, first of all, just to compliment you on your chairing ability and Yet again, I've seen you do this several times now, Julie. You pull it out the bag. You know, when we look like we're going to be there for several hours longer, you pull it out the bag and bring us back on time. So well done. That's a real skill. I do feel as well, I don't think this was a deliberate ploy by Krishni, but we seem to have a lot of quite meaty papers for today's board, more than sometimes, you know, we may have. So I feel like we've had some good discussion, but we probably could have had even more discussion given the breadth of the agenda we were covering. So that's just something to note about agendas for the future again, really. So that was my comment.
Thanks, Melanie. No, you're absolutely right. And we've tried to let the conversation flow to gain the assurance in areas where we needed it. But I'm sure some of these important items will be coming back to in future boards, I think. Krishni.
Thank you, Julia. So first of all, echo Melanie's comments. You've done really well, Julia. So thank you. Thank you for stepping in and chairing the meeting for me. As I mentioned at the beginning, it was part of a sort of agreed plan of Julia sort of doing some deputising to support me with the joint chair role, and as we were encouraged to do by NHS England. So thank you, Julia. And now that she's done it once, hopefully she'll be willing to do it again at some point later in the year. Really grateful for that. The thing I did want to highlight is we obviously, as ever, with our Council of Governors, we like to provide assurance on a particular area that we've discussed at our meeting today, or indeed in earlier meetings. So one suggestion might be the staff survey results, which I'm sure governors would be interested in, but I just wondered if NED colleagues had any other thoughts about areas we might want to cover. Our next council meeting is in June. So it's just really a thought, a prompt really to say, was there anything that we would like to take back to the Council of Governors to share further? So I'll pause there. Thank you.
Scott, I'll just bring you in for that.
Very quickly, I support the comment that Krishni's just made. I think the annual survey results would be positive, but then so would the gender pay gap detail as well. I think that, you know, could be part of a linked session, and I think that would be a positive as well, despite the challenge I made earlier.
Thanks, Scott. We'll let Chris go away and have a think about that one, perhaps with Krishni and with Richard to take that forward. In which case, I would like to spend just one more minute thanking Scott on behalf of the board, totally, for all your commitment, passion, drive, enthusiasm, wisdom. I'm going to say this, you're like a wise owl. I was going to say old owl, but that's not right. So you're a wise owl. Wise Glaswegian owl that I've had great pleasure learning from over the last few years, and I'm sure on behalf of everybody a huge thank you for all your commitment, particularly for patients, service users, staff, etc. And I'm sure we'll see you in other meetings throughout the rest of the month. I think you've been incredible and your impact has been huge. So thank you. I think, did somebody just put their hand up? David, did you just put your hand up?
No, press the wrong button.
Oh, sorry. So Scott, I'm sure we haven't got time for everybody to individually thank you, but we will do over the next month or so. So thank you so much. And thank you, public and anybody observing, to everybody that's contributed with their papers today. Really good discussion and debate. Thank you for our patient story this morning, which was phenomenal. And I shall remember that for a while. And for other colleagues, we'll join and regroup at 1:30 for our private board session. And so thank you very much, everybody. Have a good rest of your day and see colleagues in half an hour. Thank you.
Thanks, Julia. Thanks, everyone.
Thanks, Julia.
Bye-bye.
Thank you. See you later.
Bye-bye.